WebEx, Teams, whatnot.
Yeah, there's something called Blue Jeans, which I've tried, and which is really high quality, but very, very exclusive and expensive. So this got put together at very short notice. And I'm glad you could make it, because I think this session really depends on your presence to a substantial extent. I think we tried to get Dr. Soumya Swaminathan also on board, but I think the notice was really too short for her as well, and she had other commitments.
Yeah. No, I wouldn't have expected her to agree, but clearly the timing is also not very propitious.
Yes, 6 in the morning.
That will be 6:30 in the morning for her. So
yeah. So Arun, I'm unable to rename myself in this particular.
So you can just click anywhere on your screen, right click and click on rename, or I think Molly can do that for you.
That's okay. Molly, just rename me as KK if possible, but otherwise it doesn't matter.
Sure, sir, I can do that.
I don't know if it's important. We're going to ready to start, so don't bother. Not important.
Done, sir.
Just checking my audio as well. Am I
Brilliant.
audible?
Yes.
Yes, Nazneen.
I think we can begin now. We'll have participants joining us, but it's almost 10 now. So is it all right if we start? Okay, thank you so much. So firstly, I would want to welcome all of our speakers today, all the participants to our session, to Medical Students Association of India and its session with the Public Health Foundation of India. Today's session is extremely special for us today, and the topic which we are going to talk about is research in public health, optional or essential. So the name of the session itself gives you a pretty good idea as to what we'll be talking about ahead, and I'm sure this is something which a lot of medical students are wanting to know, are wishing to explore more. So that's what we'll be doing in the session today. We have eminent speakers from the Public Health Foundation of India today, and without any further ado, I would want to start. Just before that, I would also would want to just introduce myself. My name is Molly Mehta, and I'm working as the Vice President for External Affairs at Medical Students Association of India. And to start off with our session, we ha- we firstly have Professor Srinath Reddy, who is the President of Public Health Foundation of India. Just to give an introduction to all our participants and to get to know him more, Professor Reddy is a cardiologist and an epidemiologist, and a former head of the Department of Cardiology at the All India Institute of Medical Sciences. He's an internationally renowned public health and human rights advocate. He has been conferred with several honorary doctorates and by universities across the globe, and is a recipient of various awards and honors, including the Padma Bhushan Civilian Award from the President of India for his contribution to public health. Thank you so much, sir, for joining us for today's session. As Dr. Krishna already mentioned that we organized the session at quite short notice, so it means a lot to us for all of you to join and take a part in this session. So over to you. Please feel free to take the ground, and let's begin the session finally.
Thank you, Mauli, and good morning to all the friends on the net who have joined this webinar. I am grateful to the Medical Students Association of India for having invited and then partnered with the Public Health Foundation of India for this session, which certainly opens a big gateway to our discussion on why research and pursuit of science is also integral to medical education and the practice of the medical profession. Charles Mayo, who is the most celebrated of the Mayo brothers, along with William Mayo, who founded the Mayo Clinic, said there are two objects of medical education: to heal the sick and to advance the science. At that point in time, he did not speak much about public health or prevention, but certainly I would like to add one more: in order to prevent disease and promote health, not just heal the sick. But advancing the science is absolutely integral to all of them. And one of the important elements of medical education is to prepare the young medical professional in training to understand the scientific method, to get excited by it, and then to adopt it both in practice as well as in exploring new avenues of knowledge, which will ultimately advance the science for human benefit. Now, clearly, one of the very important elements that we are looking at when we try and understand how best knowledge can be applied to our clinical practice or public health practice, or even to shape policy related to the health system and public health action, we are really looking for what we feel is the nearest approximation of truth at that point in time. So we say, okay, this appears to be the truth, so let us try and adopt it to practice and policy. Now, unfortunately, what we perceive as truth and what we want to pursue as truth has several elements which are waylaying it and are distorting it and creating a fog around it on the path to our discovery. One is chance or random error. Somebody said chance is always the eternal alternate hypothesis. So we have to deal with chance and we adjust it for it with statistical methods. Then there is bias, which is systematic error, which brings in a very clear-cut distortion in a particular manner because of variety of reasons in the design or measurement. And therefore, we have to try and correct that bias as well. Avoid it in design as much as possible, but certainly look for it when we are analyzing research and try and correct it if we can, or reject it if bias plays a big role in distorting the findings of research. Then we are also dealing with a special category of bias called confounding, where the relationship between the exposure as well as the outcome is also intermediated to some extent with a third variable which influences both exposure and outcome and acts as the biggest distractor there in terms of the relationship and the interpretation. So therefore, we have to look at that element as well. And then there are, of course, what are called covariates, which may not necessarily be confounders, but like age, gender, and occupation, sometimes all of these sometimes are covariates that we need to adjust for. Age and gender, of course, most often are important covariates that you need to adjust for. So these are some of the things that we are really looking at in terms of our quest for truth. But then there is also the element of fraud, which is now coming up more and more often in medical literature. So even while we're searching for truth, we must keep out a keen eye to detect fraud when it occurs, and then reject whatever is the publication, even in a prestigious journal, it appears to be fraudulent, or if it is methodologically flawed. Then there are, of course, statistical errors which steer you the wrong way. What's called the type 1 error, where you can actually get a false positive result. And particularly when you do too much of significance testing and you get multiple significance testing with many p-values, you may land up with a finding which appears to be positive by chance alone. The second, of course, is when you miss the true association, even when it exists, because your sample size is too small, which is called the type 2 error. An eminent American statistician also said there is a type 3 error, which is using the right methodology but to answer the wrong question. So even while setting your question, you must find out what is the relevance of this to your clinical or public health practice, what is the biological rationale, what is likely to be the impact in terms of changing policy or practice, and affordability, and so on. So you must also frame your questions properly. And therefore, the scientific method is absolutely essential, even for refining and defining the questions that you're asking. But the important thing is, if you are undertaking research, of course, you must understand the methodology well. But even if you're not undertaking the research, if you're a practitioner who wants to practice good medicine or good public health, but you want to apply knowledge and use it well to achieve your objectives, then you must understand the strengths and weaknesses of research so that you apply the products of research in a very discriminating and intelligent manner. Just to give you an example, if you pick up, for example, even one of the things in clinical trials, for example, is that you must also be looking at all the important clinical outcomes which are relevant. There was a study called the chaos study, very appropriately called. It was actually the Cambridge Heart Antioxidant Study. Now, that particular study looked at the impact of oxidants on heart attacks and heart attack-related death. Then they published a paper saying taking these antioxidants actually reduces non-fatal myocardial infarction. Appeared to be great news. But when you looked at the data, actually in the antioxidant group, which contain a lot of beta-carotene, the heart attack-related deaths were more in the intervention group. Therefore, there was a survivor bias. Those who did not die of heart attack lived on in the intervention group, whereas those who actually, basically, therefore, the mortality was less in the control group, and there was more sick patients surviving, and they had more heart attacks. So that study ultimately had to be rejected in terms of clinical applicability. So you have to keep a very keen eye to watch out for some of these distortions as well. But when you look at diagnostic tests, for example, which are very much now being used for COVID-19, we talk about sensitivity and specificity, which are test characteristics. But in a clinical medicine, when you're applying the test, however good the sensitivity and specificity are to a particular patient, you just don't want to know how the test performs in a group of patients, but how does it actually translate into a diagnosis for the patient who is sitting in front of you. So that's where you're looking at positive and negative predictive values, and also something called the Bayes theorem, which also tells you what the pre-test probability is, and accordingly you interpret your test result. Just to give you an example, as cardiologists, we're very fond of doing exercise tests. And when we do this exercise test, in a treadmill test, suppose there is a 2 millimeter ST segment depression in a 60-year-old male diabetic smoker who is hypertensive, who has chest pain on climbing 2 flights of stairs, we are fairly sure that this person has blockages in the coronary arteries. But suppose the same ECG result was obtained in a 25-year-old woman with anemia, with atypical chest pain, we know that the pre-test probability is so low that even that test result is unlikely to elevate the post-test probability to beyond 25 or 30%. So there are a lot of things that you need to understand even in the context of your clinical judgment. And particularly when you are looking at so-called predictive values, positive and negative, then you also have to look at what the prevalence is. Sometimes these tests which are developed in hospital conditions are shifted, transported into the field conditions, public health. Antibody testing for COVID, for example. You validate it in a hospital setting, and then you transfer it to a population setting where the prevalence is very low, then you're going to end up with lots of false positives, and you will end up labeling people. Particularly if you do that in a case like HIV, you end up labeling a lot of people unnecessarily as being HIV positive. So you need to understand all of these dimensions if you're going to be really interpreting how to use these tests appropriately, whether in clinical medicine or in public health. Similarly, there are multiple array of tests now available in variety of conditions. Do you use them simultaneously or sequentially? What is the incremental diagnostic value of each? What is the decision failure rate if you don't apply a test? All of these are the things that you are to be asking for yourself, because you have to use your tests intelligently, both to reduce the biological cost of multiple tests as well as the financial costs. But then at the same time, you don't want to miss a critical diagnosis. So how do you actually combine these tests? I'm just giving you a few examples to show that there is a lot of excitement in asking these questions and answering these questions, because they're relevant to your daily practice, even if you're a clinician. And certainly if you're going to be also combining research as an element of your life, then you certainly need to understand the research methodology as well as its strengths and limitations, and then apply it appropriately. So there is, I would say, a great deal of romance, because ultimately a doctor who becomes also a researcher, or at least understands research methodology and applies it to interpreting knowledge to improve policy and practice, I would say they're all knowledge detectives, like Sherlock Holmes. You're going to be the Sherlock Holmes of medical research and practice. And interestingly, Arthur Conan Doyle, who created Sherlock Holmes, was a doctor. So he asked the right questions, he interpreted the answers very intelligently, and came to the right conclusions. So it is our quest for truth in understanding an individual patient's medical condition, or understanding how a large population group is responding either to a disease-causing agent or to an intervention that is intended to control it. All of that requires a scientific bent of mind, a scientific temper. It matters to us in our everyday life or practice. Therefore, this particular introduction and interaction is going to be very valuable to all medical students. And we must ensure that the neglect of research methodology and the spirit of science, which has unfortunately eroded our medical education, should be corrected, so that we actually produce young doctors with a much sharper scientific bent of mind and with a skill set that is able to ask, answer, and apply the right questions with the right answers. Thank you.
Thank you so much, sir. I feel the beginning of our session couldn't have been any better than that. We still have some time for this session. So if any participants have any questions, we can take some questions for the next 5 minutes. So please feel free to type it out in the chat box, and I'll be asking your question to Reddy sir, and then you can. I'm sure you'll get the answer to your question. So feel free to type anything in the chat. Type any question in the chat box that you want to ask. If there are no questions, we can proceed with the session ahead. I'll wait for a minute for anybody to type out any questions they might have.
Mauli?
Yes, sir.
I think we can engage Dr. Reddy with a few questions from us at this stage, even though we do have a formal panel discussion that follows.
Yes, sir.
The one thing that that struck me, Dr. Reddy, as a medical student, and now when I look back on those years, is there are so many really illustrative stories of how science needs to be applied correctly, how data sciences need to be applied correctly to a number of clinical situations. It's amazing that even today, the concept of Bayes' theorem has not been internalized by most physicians, by most people. As a result, tests continue to be very incorrectly interpreted. It's only when I did my cardiology that I actually got taught the Bayes' theorem. I think it's actually a very simple concept that needs to be introduced much earlier. There needs to be a transformation in the way we bring in these concepts through some very vivid examples, isn't it?
Absolutely. I think it's very, very critical that the context is very clearly understood and related to our interpretation of data. In fact, there's a very nice book by Nate Silver. Nate Silver is the person who, till very recently, predicted every single presidential election of the last 20 years very correctly, including each state level result. And he's a statistician, actually, who won fame for his baseball predictions and analysis. And he writes very well that, that basically it is the Bayes' theorem that has helped them make all the predictions, because the context is absolutely relevant, because without context, the data become meaningless. So I think it is very critical that we do that now. We teach with right examples the medical students to understand the context as well, and not to be just blinded by a set of numbers.
Mauli, can I ask a question? Actually, I tried to write the question on the chat. The chat is disabled, so maybe one of the reasons why people are not asking questions.
So the chat, the thing is that the chat is directed towards only the host to avoid any unnecessary conversations in the chat, apart from questions or any irrelevant topics. So we do have 3 questions from the participants. Yes.
Why don't you ask that?
My question to Dr. Eddy is that Malcolm Gladwell said that if you are to become an expert or if you are to become a leader, you need to do 10,000 hours of work in that area in which you're going to become a leader. Given that you become a research leader and a public health leader, what was your 10,000 hours of work?
I really didn't count, I suppose. That is one of the things that you must learn to avoid, not to count what you're doing. Because if you're only looking at the clock, you don't look at what you need to do. So I don't count my hours. But I don't consider myself a leader. I'm still a student. I'm still interested in learning, and I continue to learn. But I think the most important thing is to have that level of inquisitive mind and the humility to learn from everybody and every possible source of knowledge. It is not that we have to become absolutely super gurus in any area with 10,000 or 20,000 hours of knowledge and application. And particularly in public health, there are so many new things to discover and learn each day.
I thought you were going to say in your early years of research, you are involved in every aspect, including washing of the test tubes and things like that. So
That I did. Washing urine test tubes and urine bottles in Ladakh, and I've done all that. But that's all part of doing research. But then there is also as I said, research has a certain degree of excitement and romance to it, of trying to gather data and interpret it and then find out what the data reveal. But you have to be sort of in love with what you're doing in order to enjoy even washing urine test tubes.
Mauli, some questions from the audience?
Yes, sir. We have a couple of questions from the audience. So one of the questions which the audience has asked is that, what do you think are the required categories of public health that required to be researched?
Well, I think everything in public health requires to be researched. If you depend upon what are your overall concepts of public health, what is causing disease in a population? Could it have been prevented? What are the elements that could have promoted good health in the population, which actually reduce the susceptibility to disease, like COVID, for example? What are the things in diet which produce innate immunity and protect you from COVID, for example? Or how do you detect early before complications develop? Are there good referral systems for not only diagnosis, but for treatment? And are the health systems adequately equipped with people and whatever are the infrastructural requirements to look after? You see, a medical consultation between a doctor or a nurse and a patient is an individual consultation. But even whether that consultation is taking place in the right kind of environment, with the right kind of equipment, the right kind of support systems, is a systems issue. So that again is an important area for research. Then are drugs available, accessible, affordable, even if prescribed? That's again a public health issue because it's a health system issue. So health system deals with policies like, for example, tobacco taxation or helmets or seat belts. It also deals with systems issues like how do you actually finance a health system? How do you build a skilled health workforce and avoid maldistribution across the country? It also looks at community engagement and empowerment. And how do you behavior change? Are people gathering in crowds even during the COVID time? Are they wearing masks? So every area of public health is essentially researchable, including the economic implications of it, cost effectiveness, etc. But equity is an important element as well. You want the benefits of science to reach everybody, all sections of society. Therefore, we say in PHFI, knowledge to action, action to impact, and impact to equity.
Thank you so much, sir. I think we can take one more question and then proceed with the next session. So one of the questions which has been asked is that how could doing research be beneficial for pioneer students of MBBS during the COVID-19 pandemic?
Sure. I mean, for example, just to give you one example, you're reading about all these antibody surveys that are there, right? Now, these tests have had their sensitivity and specificity defined in a clinical setting, in a hospital setting or a big lab setting. When you transport it to a completely different area, like a field area, community, you have a very different prevalence rate. Your sensitivity and specificity will not change, but your predictive values will change, and you get a huge amount of false positives. And that actually changes not only the labeling of the person, but also your estimation of prevalence of the condition in the population. So you have to interpret some of those things even to your relatives or friends when they say, oh my God, antibodies are showing 23% in Delhi, 17% in Ahmedabad. So you say, okay, there could be a lot of false positives, but then these are the reasons why the false positives could be there. But much more importantly, you can also look at what would be the kind of potential benefits of various public health measures that are being adopted in your community there or in your field area, and see whether they're actually making a difference to the cases coming to the hospital, the nature of cases coming to the hospital, some of these things that you could actually look at some of the associations with some of the public health practices and clinical outcomes.
Thank you so much, sir. I believe that might have cleared a lot of questions for a lot of students regarding why research and how can students excel in the same being MBBS students, because that is still something which is being worked upon and being explored by students to a great extent as of now. Having said that, I feel we can move to the next session of our guest lecture series. Firstly, I would again like to thank Dr. Reddy sir for answering the questions and for beginning on such a positive note for today's session. Our next session is by Professor D. Prabhakaran. The name of the session is Retrospectoscope. I'm sure the name of the session itself might have intrigued and would have raised the curiosity of a lot of students out here. before we begin the session, to brief you all about Professor Prabhakaran. He is a cardiologist and epidemiologist by training. He is a professor and a visiting scientist at the London School of Tropical Medicine and Hygiene, Emory University, Harvard T. Chan School of Public Health, McMaster's University, McGill University, and Simon Fraser University. He was listed as the highest cited researcher in India for the period 2009 to 2014 by Scopus and the Department of Science and Technology, Government of India. Sir, it's an honor for us to have you in our session today. Over to you. Please feel free to go ahead.
Thank you, Molly, for that very kind introduction, and a very good morning to all the friends on this program. First of all, my thanks to MSAI for organizing this at such a short notice. And to be here, and it's a great privilege to be talking to you all. Initially, the topic given was Professor Prabhakaran's letter to student Prabhakaran, and I thought it was very pompous and somewhat imperious. So I changed the topic a little bit because being an eternal student as well as a teacher, it gives me a good perspective. I think it gives a good perspective as to what I should be writing. But I don't want to really write a letter and show it to you. What I want to do is just share some of the potential contents of that letter and seek your opinion as to whether that's right or whether you want to add anything more or if I have missed out something. So with this in mind, I first asked myself a question. Am I the right person to write this letter? Secondly, what should be the contents of this letter? And these are the two questions. And in this process, I might talk a little bit about how to ask a research question. So I thought, just to describe myself, I thought, let me describe my career. Like Dr. Pratima Murthy, who was going to join in the panel, was 1 year senior to me. I studied in Bangalore Medical College in between 1980 and 1985. Then I came to AIMS in 87. I did my MD and then DM in AIMS and then continued as a faculty. Somewhere in between, I went to McMaster University to train in epidemiology and then took full-time research over the last 15 years. So just to summarize the research that was conducted in the last 15 years, and the most satisfying outcomes were that we established cohorts and biorepository for future research. We scaled up some of the low-cost solutions, which I'm going to talk a little bit. Then we built a cadre of independent researchers, synthesized and disseminated information, and built large-scale collaborations. Now, the question that I wanted to ask myself was, were the seeds of research aptitude and public health interest sown in medical school? So I want to share an experience as a medical student in 1983. So in 1980s, this was the year 1983. This is the hospital in which I worked. This is called the Victoria Hospital. It's still called Victoria Hospital. And there was a pediatric section called the Vani Vilas Hospital. Just to give a perspective of how things were, bell bottoms were very, very popular those days. It's coming back now. I thought it was dead, but it's coming back. I had a lot of hair then, and you can see now how much I have. But in terms of the diseases, it was a predominance of pre-transitional diseases, which we mean that it was diseases of nutrition, undernutrition, infectious diseases, reproductive and child health disorders, and so on. So you can see these were the two common admissions in Vani Vilas Hospital where the pediatrics department was. This is a marasmic child, and this is what is called as kwashiorkor, which I don't think any of you have ever seen in the current era. This is the kwashiorkor is protein energy specifically protein malnutrition. Marasmus is total energy malnutrition. The second thing was poverty was quite rampant. If you look at this graph, in the 1980s, nearly 40% of the national population, 40 to 50%, were below the poverty line. And the good news is it's come down considerably. It's come down to almost 10%. We still have some poverty of that level. The other thing which I wanted to tell about the economy at that time was we had an artificially inflated exchange rate. Our US dollar was constantly at 8 rupees. But when we liberalized, it of course fell, and now we have around 77 rupees. The reason why I'm saying that is somewhere along that, in that time, there was that pride that our economy was good, but you can see how dysynchronous it was with a high poverty level and high levels of pre-transitional diseases. So what did the medical students think in the 1980s? They all thought about their clinical career. They wanted to become doctors. Many of them in those days, specialization was not universal. Nearly 30 to 40% of the people decided that they would go into family practice or general practice. And they would think of how to set up a practice or how to get into post-graduation, which is common even now. People thought about immediate solutions to the in-your-face problems like kwashiorkor and marasmus. How do you get a solution to that problem without actually doing major research at that time? Research actually was very low on priority, and the reason for this was it was not as easy now. You get onto a PubMed, you get onto your library, and then you get all the articles that you want. But many of you would not have seen this. If I had to do research and ask a research question and search for articles, I would go into these big books called Index Medicus, which were produced annually. You can see from 1890 onwards, we had these Index Medicus till say 1980s, and you would actually, these were 1,200 pages book, and you would actually go and search for the articles. Then it was a big exercise getting those reprints. So there were other challenges too. One of the challenges which I spoke was clinical care versus teaching versus research. Which area should I get into? That's what medical students used to think. Research had an unattractive remunerative option. It's changed considerably now. The other big problem at that time was there was copycat research. Some research used to be conducted in the Western countries, and we would repeat that research. Like I remember the commonest thesis topic for postgraduate students in those days was 20 interesting cases. So they had to get 20 interesting cases, write about them, and the thesis was done. The second thing is a lot of people thought research means asking very esoteric questions without realizing that the simplest questions have the most profound answers. There were institutional challenges. There are differing priorities, like at that time or even now at All India Institute of Medical Sciences, for example, there are a lot of patients. Doctors have time for clinical service. Because there are so many patients, it's difficult to devote undivided attention to research. So you have to do both. There were infrastructural issues. There were not many avenues for research those days, and there were funding issues. And of course, there were systemic challenges then. So the then young medical students' questions and the professor's answers are given here. The then medical student asked, is it dichotomous or a continuum? I mean, should I do research? Should I do clinical medicine? Or should I do both? Or is it a continuum? Is it the fact that there are some people who are naturally prone to become researchers? Or is it the environment within the medical college or where you're working that induces you to do research? Some people thought just doing research and getting into a research career was madness and a risk-prone behavior. So the question was, is it all or none or either or? So what would be my answer now, having gone through this whole 30, 40 years of clinician researcher role? My question is, do we really need to ask this question? Because I think everybody can undertake research. Can a medical student undertake research without any research experience? I will give you an example, and you can see how you could actually, without having any knowledge of research, really do something meaningful to change practice. So when we saw these patients of marasmus and kwashiorkor, the most important thing that they needed was that they needed to be fed so that they don't relapse back into kwashiorkor or marasmus. They needed 1,000 calories when they are around 4 to 5 years of age or 6 years of age. Now, how do we get that 1,000 calories in 1 rupee? The reason why I showed the dollar exchange rate and the economy was in 1983, 1 rupee was equivalent to something like 100 rupees now. So that's the kind of exchange we had. So the question was, can we get 1,000 calories in 1 rupee? And this was a question posed to me by one of the lecturers there. And he said, if you guys can work it out, that was a simple exercise which was given to us. And we can use that to put it in our wards and in our OPDs so that our postgraduates can use. So with this question, a bunch of us got together and we went and found out what do poor people commonly eat. We interviewed our own mothers as well as mothers of those kids about cooking practices. We looked at the nutrient content of commonly eaten foods. We visited shops to find the costs of food. And we created a discharge advice as to how we should give a 1 week's diet. It had to be different, it had to be tasty, it had to be local. So we did that, and it was quite a success. Now you see, each of these has an important research question. In the first one, we are researching the cost. In the second one, we are looking at nutrition research. Interviewing mothers would be qualitative research. I didn't even know qualitative research existed till around 15 years back. Then the next one is nutrition research. Visiting shops is equivalent to a survey, and creating a discharge advice is implementation. So without even knowledge of what you're doing, you actually have used several research questions here. So every medical student is capable of doing research on their own. Now moving on, I got a grant as an intern of around 5,000 rupees, which is a large amount of money in 1985. So for me, what was the different for me that stimulated me to think of research? This gentleman, he was a lecturer in a different medical college. We met somewhere because he was treating my grandmother, and I found him very, very astute clinician, and I wanted to learn from him. And I would go to his clinic sometime, or go to the hospital where he worked sometime, and he would teach us the art of clinical medicine. He was such an astute clinician that his clinical observation led to an important research area. He identified, I mean, we all knew that bluish discoloration of the gums and abdominal colic, it could be lead poisoning, and he did and confirmed that lead poisoning in 3 or 4 patients in over a 2-year period. And he said this is quite rampant among the printing press workers, and we should do some research about it. So I wrote this research project, and we worked with Regional Occupational Health Center in Bangalore. And actually, without knowledge of research stratification, we chose large industries, small industries, and in each of these, we assigned a certain number of people. We did a comparison without knowing case control comparison. We did choose printers. We did people who washed the machines, and people who bound the books, who had the lowest risk for lead poisoning, and showed that lead poisoning was present among the printing press workers of Bangalore. So you can see, I mean, Hemant Murthy was my batchmate, and I did all the work. But those days, the supervisor, it's not the same person, this was a different person from the Regional Occupational Health Center. He helped us write this paper. So many medical students would say, I want to do something big. I want to change lives. The question is, how do I achieve this? The answer is very simple. Think very big. Think however big you want, but start small. Acquire good mentors. Collaborate. And if you collaborate, the whole becomes greater than the sum of the parts. As Alvin Toffler said, you've got to think about big things while you're doing small things, so that all the small things go in the right direction. And second is, if you have to have a strategy. If you don't have a strategy, you're part of someone else's strategy. So let us look at one of the big questions that is needed. Hypertension is a big public health challenge. The WHO set a target in 2012 saying that by 2025, we have to reduce raised blood pressure by 25% across the world. So the big question that we asked at that time was, can we reduce high blood pressure burden in India by 25% in the next 10 years? This is the biggest question possible for hypertension. Now, what are the elements that go into this question? Several things. We need a situational analysis. We need epidemiological data like what we are having for this COVID-19 infection. We need surveillance. We need to know what works and what does not. We need clinical trial evidence. We need to know whether the policymakers will be receptive. We need to know, are there enough financial resources? Do we have enough human resources? And will the non-health sector be receptive? And will people accept our intervention? Is there enough awareness? So you can see the medical student can embed several questions, simple questions, into several of these sub-questions. And actually, we build on many of these to create a whole program. I'll give you an example of that kind of a program that we created in the last 10 to 12 years. So we asked a question, can we demonstrate the efficacy of electronic or IT-based, smartphone-based decision support system in reducing blood pressure at 1-year follow-up among patients with hypertension? So we started off with a PhD thesis. These are the 2 PhD theses. where we did a comparison of the decision support system against few experts. And the second is we tried to scale it up in the state of Himachal Pradesh. But of course, we worked at multiple levels, tertiary care, community care level, and all the various possible levels, and also looked at a composite set of interventions which looked at multiple things, including depression, alcoholism, tobacco, and diabetes. Once we found it successful, we implemented across 2 states in India. Now it is being evaluated at the national level. My colleague and friend, Dr. Nikhil Tandon, will talk about this a little later. We also helped the WHO convert some of its PEN package, which is essentially the things which community health workers use and their primary care physicians use, into an electronic platform. And we are looking into implementing it in private sector. So as you can see, we asked a very large question, did a small research on one aspect of that question, then showed that it works in multiple places, and then we scaled up, and now we are making it sustainable. The second thing is about awareness. We need to create awareness among the people to accept it, but you need to do it on large scale, and we need to see this kind of awareness, does it work as a surveillance mechanism. So we did what is called as a May measurement month. In the month of May, every year, this year it didn't happen because of COVID, from 2017 onwards, 2017, 2018, and 2019, we did this May measurement month. In the month of May, we chose volunteers, we asked volunteers to measure blood pressure wherever possible. So we had 50 plus participating institutes, 500 plus screening sites in India, more than 20,000 healthcare professionals were involved, and more than close to 1 million individuals were screened in 2 years. Now we can see the power of using voluntary data, and I would say a lot of medical students participated in this program. So clearly there is a role for medical students in research. Now, many medical students ask, or many people ask me, are the research questions different when you are young and when you are a professor? And I think it is the same. I think these are the 6 elements that you need to ask when you are designing a research question. What is the research question? It has to have all the elements of the questions that you're asking. You need to know why you're doing the research. You need to know how you're doing it. You need to know the location, the place where you're going to do. You need to know the time frame in which you're going to do. But most importantly, you need to have that innovation and that novelty, as I call the wow factor, in your research question. If you do this, if you embed this, and I think any funding agency will be able to fund your research. So the question of clinician or clinician researcher or full-time population-based researcher is actually a non-question for me, because it is a continuum. You start as a clinician. For every individual patient, you're asking that question, why? How do I do it? What will I give? So it is actually a type of research question. And as a clinician, it is the role of the story, apocryphal story, which I want to relate. There's a vast ocean, and there's a young boy who sees the silverfish coming out of the water. So he takes them and puts it back into the water. And then a gentleman who was walking by asked him, young boy, what are you doing? This ocean is vast. Why are you trying to do this? The young boy says, at least I made a difference to that one fish. Similarly, as clinicians, you're making a difference to that one patient. As a clinician researcher, you're looking at the population and you're thinking, oh, I'm doing this at a single patient level. Can I expand it to the population? So you have the dilemma when to move from being a full-time clinician to a researcher. And finally, you move on to full-time research, addressing the need. And then you become a public health advocate to address the public health needs. Now the question is, will the twain meet? This is a very rhetorical question that I'm asking. I think this is like a Venn diagram. Public health, clinical medicine, and research intersect, and all of which are important. Now, public health as a holistic context means that it has a broader context, whereas research is reductionist because you do a small bit of research, whereas clinical medicine has to have that, pickup, looking at some of the issues in terms of diagnosis, but you need to look at the patient as a whole. So I am an agnostic, but I'm quoting from 2 scriptures. So the Bhagavad Gita, it says, right work done as a form of prayer and is one of the paths to spiritual development. And from the Bible, there's time for everything and a season for every activity under the heavens. So in this journey, please always acknowledge your patients, your research participants, your mentees, mentors, family, is an extended family. So you need to share what you know. Even as a medical student, you can share it with your juniors, so become a mentor. I have been fortunate enough to have some of the brightest mentees who have made our program a very big success. And these are several of my mentees who have done extremely well. They have become leaders in their own strength. And I also follow the Vasudhaiva Kutumbakam policy. So there are lots of international trainees who have come in and have taught me a lot of things, and I've learned from them quite a bit. Don't forget the mentors who shaped your career, and there are these two mentors who extensively shaped my career, one of whom you just heard. So because of him, I moved from pediatric cardiology to preventive cardiology, and that's helped me a lot. Finally, thank all your collaborators. You could use French word mercy to thank all the collaborators, but if you forget, plead in English for mercy. And don't forget your family, because family is the fulcrum in which you work. They are very important. They sacrifice a lot for the time you don't give them. And so think of your family, and think of all the people who work together and all the friends you have made on the way, so that they have become your extended family. With this, I end my talk, and thank you for this opportunity.
Thank you so much, sir. That was a beautiful end to end the talk on. We have many questions from our participants in the chat box. We can take two questions and then go ahead in our session for today. One of the questions which a participant has asked is, cardiology is a very interesting branch from a research point of view, but how does it correlate with clinical practice of cardiology? And they've also the participant has also quoted one of the personal experiences that my cousin is a cardiologist, and says that it's just beta blockers, ARBs, and PCI.
So that's a very interesting question. Let me tell you that cardiology is one of the fields in which research has got translated into practice immediately. Let me give an example. Dr. Krishna Kumar, who was on this panel, who is a speaker, and I were residents at All India Institute of Medical Sciences. He was a little 1 year senior to me, and we were working together. And we read in 1988, an important paper was published, which is called ISIS 2, which said that if you give aspirin and if you give thrombolytic therapy in combination, 47% of, I mean, close to 45%, I don't remember the exact number, but it's something like that, 47% of the mortality within 6 weeks could be prevented. So we read that together, and we came back and implemented it in our practice the next day itself. I mean, All India Institute gave you that freedom. If you can justify, you can use the evidence and treat. So what more research translation can you get? The second thing is Dr. David D. Wood in 1960s, because before 1960s, people thought heart attack, the thrombus that was found in the coronary arteries after a heart attack was a post-mortem phenomenon. But he asked that question, and he proved that it is not post-mortem, it is ante-mortem. Because he made that it is ante-mortem, all these therapies such as thrombolytic therapy and angioplasty and other things came about. It is not only about beta blockers, ACE inhibitors, and statins. There are lots of unexplored areas. Like, for example, you can look at the socioeconomic determinants. Why are some patients, when we put them on treatment, continue the treatment to the T, but there are others who just don't take it? That's an important question. How does mental health interact with the treatment that we give? Or for that matter, heart failure is a big and emerging area. Why is it that even with patients with preserved ejection fraction, the mortality is high? How do we prevent those mortalities? So there are any number of research questions that can be asked. What is the interaction with other diseases? Like you saw the COVID era, if you have heart diseases, the mortality is high. Why is it high? There are lots of questions you can ask.
Thank you so much, sir. The one question which a participant has asked is that even though medical students have similar research questions like a researcher, but due to time constraints, the quality might not come out good because they don't go deep and read articles. We also don't have access to many articles. So how to improve the quality of research done by a medical student to the standard of a researcher, to overcome these two barriers?
I think one of the things that everybody has to do if you have to do high quality research is get your research question correct. Your research question has to have those, it has to have a research question, but it has to define the population, it has to define the place, it has to define the duration, and it has to define the intervention. Or if it is a observational study, it has to define as to what you're seeing. You have to talk to a statistician and get the right sample size. You have to be practical so that you can do it within the 2 or 3 years as a medical student, because your resources are also constrained. But whatever you do, do it with the highest quality. Don't compromise on quality. If you are collecting data, don't compromise on that data. Be very diligent. And with that, you will be able to do, even with your limited time, you can ask that important research question and answer them. Like I showed you the example of the Kwashiorkor marasmus. It didn't have a research question, but it had a solution.
Thank you so much, sir. And thank you again for such an informative talk about how medical students can explore this beautiful area of research and to answer the questions. We have more questions, but we might have to go ahead in the session for today because of our time constraint. So moving on, the next session will be taken up by Dr. Arun Jose, and he'll be talking about choosing a career in public health. Dr. Arun Jose is a public health specialist by training and currently leads various capacity building initiatives for physicians in India. He is a global public health leader, fellow of the Rollins School of Public Health, Emory University, Atlanta, and he is currently pursuing his PhD in implementation sciences from the University of Maastricht. Dr. Arun, over to you.
Thank you very much, Molly. A very good morning to everyone on this platform. At the outset, I would like to thank the Medical Students Association of India and the organizers of MedFest 2020 for giving me this opportunity to speak on this very wonderful platform. So I've chosen a topic that's very dear to me, and it's also a sharing of a personal experience. Every year, more specifically during the time of the entrance results, I get a flurry of phone calls from my students and their friends and people who've just found me on social media. And all of them are confused about whether they should choose a career in public health. They don't know if they have the aptitude for it. They're completely unaware about what opportunities are there in public health. And those who know they have the aptitude and are aware of the opportunities have a bunch of obstacles. And so I thought I would walk all of you through this journey that I take my students through. But before I begin, I would like to address a matter of grave concern. The fact that these students called me at the time of the entrance results made me think that they actually chose their area of specialization only at the time the results were announced, and they had never given it a thought before this. And so I want to ask each and every one of you on this call, have you chosen your area of specialization yet? And this is for the medical students, the interns, and people preparing for their PG entrance exams. And if you haven't chosen an area of specialization yet, what I would like you to do is stop for a minute. Not a minute, since we don't have so much of time, but in your mind, choose one area of specialization. I'm going to wait for 2 seconds. Okay, I'm guessing that you guys have chosen an area of specialization in your mind. Now, let me ask you a bunch of questions. Was it based only on your love for that subject? Or have you thought about the life that you will lead after you've completed your education? Because I feel this is something that students don't really think about when they choose their area of specialization. The next question that I want to ask you is, will you be good at what you do? And is the specialty that you've chosen in your mind right now the best fit for your personality and for your skill set? Or would you be able to use your personality and skill set for something better? So these are very, very important questions that I want all of you to ask yourselves right now. And for all of you who have chosen your specialty in your mind, I am 90% sure it's a clinical medicine subject. Have you ever considered a career outside conventional clinical medicine? And the thing that I want to ask you next is, if not, why? I always tell my students to keep a very open mind when they choose their specialty. And I want you, for the next 10 minutes, as I take you through this journey, I want you to keep an open mind and give public health a fair chance. So I am going to take you through a journey. First, we're going to introspect. We're going to do a self-reflection and see if you have the right aptitude. And then I'm going to try and show you what opportunities are there. And then we will overcome some of the obstacles. So according to me, there are 4 key domains that make you a good public health specialist. And if you have one or more of these, I think you would be a perfect candidate. So as I go through these qualities, I want you to introspect and think whether you fit, right? So the first one is managerial and organizational skills. Do you see yourself as a good manager? Do organizational skills come very naturally to you? For me, this was revealed to me when I loved organizing events at my college. Whether it's literary events or cultural events, I was always engaged in extracurricular activities. And I understood that I loved organizing events. The second is innovative and critical thinking. Do you think about out-of-the-box solutions for the problems that lie in front of you? Do you always ask questions as why, what, and how? Because an inquisitive mind is critical for a public health specialist. The third one, leadership qualities. Are you a leader? Do you find yourself rising up to the occasion whenever the situation comes? Do you find it comfortable to lead teams? Do you have those qualities in you? And the last one is communication. Are you a good communicator, whether it's written or spoken communication? Written, whether it's informal or formal? Do you have an inclination towards scientific writing? And if it is spoken, are you a good communicator? Are you good at public speaking? And also communication with your peers, the patients, the community, with your friends, your family. Are you a good communicator? Now, if you have any of these qualities, maybe it's time that you think seriously about a career in public health. Now I'm going to take you through the opportunities. Many a times I find students confused about what do public health specialists do. And I feel most of this confusion arises because the only public health professionals that they know are the ones that they've seen in their medical college, who are in the Department of Community Medicine. Well, I would like to say that the opportunities that are there outside is much larger, and what you see in the medical college is just a fraction of the work that public health specialists do. And I'm going to show you that. I like to divide the opportunities as both public as well as private sector. A lot of my students have called me and asked me, will I be hired? Will I be able to earn a living? So the first one is the public sector. There are millions of jobs in the central as well as in the state governmental agencies where public professionals are required. And this pandemic is a clear example of how public health specialists have actually led the efforts in preventing the spread and containing this pandemic. In the private sector, there are literally thousands of non-profit organizations working in the country, whether it's international or domestic. The international ones are the ones that are more popular amongst medical students, like the World Health Organization and UNICEF. There are many homegrown organizations within the country, like the Public Health Foundation of India, and all of them require medical professionals to be public health specialists. And there are many for-profit organizations, and by that I mean industries, corporate sector, who require public health specialists to do analysis and various other tasks. So let me tell you, public health is the one subject in medicine that opens up the widest area of areas where you can practice. So you could work in occupational health, environmental health, non-communicable disease, infectious disease. There are new areas like big data analytics, artificial intelligence in health, health technology, and the list is endless. So now I think I've very briefly shown you how many opportunities are there in public health and how and where you can work. Now let's come to the obstacles. The obstacles that people face when they want to choose a clinical medicine branch are quite obvious. They tell me that there's a deficiency in the number of seats and it's a little expensive to do. But often I found that the obstacles that people face when they want to choose public health is actually very silly and very, very mindless. And the first one is society. They think that society only considers a doctor as a person who treats patients. They don't know what a public health professional does. They seem to be ashamed about taking public health. And I would like to just say one thing. I'm assuming that most of the people that are listening to me right now are between the ages of 20 and 30 years. And I would like to say, whatever decision you make today is a decision that you live with for the next 20, 30 years. So do not base your decision on what others think, base it on what you think. And the second thing is in your own mind, where you have this picture that doctors are the ones that treat patients, and will I be contributing to society through public health? And this is where the COVID pandemic has really shown how public health specialists can work. And you've seen how the advice of public health specialists has helped prevent millions of deaths across the globe. And there's no other time where public health specialists have been even more important. So yes, I think I have taken you through a very short journey of aptitude, your opportunities, and your obstacles. But now I've done a lot of talking, and my mentors have told me that I need to show what my experience has been after I took my decision. So it's been 6 years since I completed my MD in community medicine. I started my work as an assistant professor at a medical college where I was majorly engaged with student education, with primary care, as well as community outreach. 5 years ago, I moved to my present organization, which is the Public Health Foundation of India, as a program manager. Over here, I was involved with implementation, with training of physicians, as well as in research. My key responsibilities included stakeholder management, where I got to work with almost all organizations across the globe. I was involved with resource allocation, fundraising, and I also led a team of multidisciplinary people. I was also in charge of forging international partnerships with governments as well as organizations from across the world. And I was blessed with wonderful mentors, including Professor Prabhakaran, who actually encouraged me to continue my education as I worked. I completed my PG diploma in Management of Reproductive and Child Health from Indian Institute of Public Health, Delhi, following which I was awarded the Public Health Leader Fellowship from Emory University in Atlanta. And I was also taken into the International Society of Cardiovascular Disease Epidemiology and Prevention as a fellow of their prestigious 10-day seminar. And most recently, I joined for my PhD at Maastricht University in Implementation Sciences and Translation Research. I was also recently accepted into the World Heart Federation Emerging Leaders Program, which is a prestigious program that trains 25 people from across the world. I've held other hats apart from my PHFI designation, which is I was the deputy chair for the Middle East and Southwest Asian region for the Regional Advisory Group of the International Society of Hypertension. I was also the country leader for the May Measurement Month program that was mentioned earlier by Professor Prabhakaran in his talk, where we screened approximately 1 million people for raised blood pressure. Over the last 5 years, I led 10 projects that have led to the training of approximately 4,000 physicians in 100 cities across India for CVD prevention and management. I was also involved in health system strengthening efforts in the African region, as well as in various countries of Southeast Asia. And over this time, I was also able to continue my research, and I did 25 publications in various scientific journals, and I authored 4 book chapters. I also had the privilege of representing my organization in over 40 occasions across 12 countries across the world. So this has been my brief journey, and they say that you should always look back and see whether you're happy with the decision that you made. And I should say that I'm extremely happy, and I hope that you all share that same experience sometime, and that you're actually happy with the decision. Please go through a phase of introspection before you choose your specialty. Do not feel pressured by the people around you, and make your choice based on what you like. I would like to end with 2 quotes. One is by the Chinese philosopher Confucius, who said, "Choose a job you love and you will never have to work a day in your life. And the last one is by the British journalist Catherine Whitehorn, who said, find out what you like doing best and get someone to pay you for doing it. Thank you.
Thank you so much, Dr. Arun. The session surely made me introspect a lot in terms of thinking more about public health as an option. And even though it was a 15-minute session, but it gave a very, very good clarity in terms of going in this direction. So thank you so much. We have one question from a participant which says that community medicine as a theory subject is kind of boring and a lot to remember, but sounds interesting as a profession. But sir, won't it be too much overwork as per the salary we might get? I mean, the overwork in reaching out to all sectors.
Right. Thank you so much for that question. And I'm so sorry for the image that we have created in community medicine. See, I think it's always important to apply or try to think about the practical applications of what you learn in community medicine. I'm not sure if your professors and your teachers are doing it for you, but I think every time you learn something in community medicine, try and think about where you would apply it and how you would apply it. Whether it's environmental health, I know the chapter that you guys learned, it's a very boring chapter, but I used to always end my lectures with at least one practical application for that thing that I teach them. And if your teachers are not doing this for you, I would recommend that you do it for yourself. Now, when it comes to remuneration, I don't know why there is this false notion that public health specialists are not paid. Maybe people think that we're working for non-profits, so we work without a salary. And someone has actually asked me this, and I'm not joking about it. They actually asked me, are you paid a salary because you're working in a charitable or non-profit organization? And I say that's completely untrue. So you get paid at scale as much as the clinical medicine people. So there's nothing to worry about there. And the opportunities are endless. It's very exciting to work in public health. This has been my experience, but you really need to push yourself. That's what I feel you should do.
Thank you so much. The next question we have is, what is the difference between a MD community? Just a minute. Yeah, I'm so sorry. Yes. What is the difference between an MD community medicine and a master's or PhD in public health, which would provide a better quality education and more beneficial in today's world?
So this is a question that's very commonly asked to me, whether we should do community medicine MD or whether you should do a master's in public health. I honestly believe that community medicine has a focus more on also delivery of primary care, whereas public health relates mostly to the aspects of delivery of public health, and not really in, and that's the reason why Masters in Public Health is open to all streams. It's not only meant for doctors, it's meant for everybody, and anybody can join for public health, where they teach you about health systems and health economics. All of this is taught even in an MD in MD community medicine, but they also give focus on primary provision of primary care. So you've seen how community medicine faculty and students go to primary health centers and provide primary care over there. And that's a small difference, because you are doctors, you are allowed to prescribe. And that's the reason why MD community medicine people also prescribe in primary health settings. But I would say one thing, whether you're doing an MD community medicine or a MPH or a PhD, it all depends on you. It depends on how motivated you are, how much you want to push yourself. You may get admitted into a college which is the most active or the most inactive, but it completely depends on you to drive yourself, to motivate yourself, push yourself, and actually explore other areas. And I think whether you do MPH or whether you do MD community medicine or a PhD, I think it all depends upon you, because your work is based on your skills and what you know. So it does not really, your education is there to guide you, but you really need to push yourself after that.
Thank you so much. I'm sure that this might have answered a lot of questions to a lot of students. Thank you so much again for the session. We might have to proceed with our next session in our guest lecture series. We do have questions, but we'll try to take the questions at the end of today's session if we can. And also, I'm sure that a lot of your questions will be answered as and by we go ahead in our session for today. So our next session is by Professor Krishna Kumar on improving clinical care through research. Professor Krishna Kumar is trained in the All India Institute of Medical Sciences and Boston Children's Hospital, Harvard Medical School as a cardiologist and a pediatric cardiologist respectively, and has helped establish the pediatric heart program at Amrita Hospital, Cochin, that is now globally reputed for quality of clinical services, research, and training. This program was also awarded the BMJ Award for Quality Improvement in 2014. Thank you so much, sir, for agreeing to take the session, and we're very excited to hear you out and to hear your views on improving clinical care through research. So I would like to hand it over to you.
So Mauli, thank you so much. And thank you for setting this up so well. It's tremendous. And I really cherish this opportunity to communicate with a large number of medical students on an area that's pretty dear to me. Arun's talk was fantastic, and it's going to be a hard act to follow, but I'll do my best in convincing you that there is really a lot of scope to integrate clinical research with day-to-day practice. And that's what I've done with my life and with my clinical career so far. So I'm going to ask a question to all clinicians, and maybe to students who are going to become clinicians. And I'm going to just list some answers, and I'll come back to you. I'll just leave this open, have you think about it. And I know some of the answers have already come from the previous talks, but let's explore these questions as I complete my talk. I have to say that if you need to do an academic medical care career, not just in India, anywhere in the world, it amounts to swimming upstream. It is not the natural flow of that you would like to sort of be in. So most of us do our MBBS, and then we have two options that we can do post-graduation or go into a practice. And, I think there is this UPSC exam that lets you go into job, government job right after MBBS. So there is that potential, although fewer and fewer are doing it today. After post-graduation, you can go back to practice or you can super specialize. After super specialization, you can still go back to practice or you can go abroad and get trained. After that, you can come back and you can stay abroad, which is the easy path. So whatever I'm showing you is downstream, which is the easier way of doing things. Or you can continue to come back to India, or you can come back to India and then join a corporate hospital, which is a lot of money and relatively straightforward existence. Of course, it has its challenges. Or you can try and establish an academic program, which is my story. I have essentially swum upstream for reasons not so clear to me, but perhaps driven by passion and purpose and not really caring about the consequences. And the consequences for this particular salmon that's swimming upstream can be pretty disastrous. Nonetheless, we've chosen to do it. And there's a reason why we end up doing it this way. For me, I chose pediatric cardiology, which is another aspect of upstream existence. And I had to say, and I think Prabhakar mentioned this, one of the things that shape your life, I'm sure lots of students can relate to this, is the mentors that you have. So Dr. Tandon was not just my mentor, he was Dr. Reddy's mentor, he was Dr. Prabhakar's mentor. He has mentored so many, virtually all the cardiovascular leaders of the country and perhaps many of the globe because of the standards he set as a clinician. But one thing he did all the time after his rounds, one thing that would disappoint him, there are not many things that would disappoint him, But one thing that would disappoint him is if you didn't ask questions. He says, I've done a 2-hour round with you and you haven't asked me a single question. That's not acceptable. That's the maximum he would say. So the thing that he taught us was to ask questions. And he would want to be questioned. He would want to be badgered with questions because that tested him. That really made a difference. So that's when I went. Dr. Tandon sent me to the US. I went, did my fellowship and came back in the 90s. And I chose pediatric cardiology because of Dr. Tandon. I came back, I was confronted with a very difficult situation. Not all of it has got remedied. But in India, you have 200 to 250,000 children born with congenital heart disease every year. 100,000 require correction very early. And when I came back in 1996, there were 4 centers that had the capability of taking care of these babies. And when we actually did the numbers, we figured that only 1 to 1.5% of the babies were receiving attention, the rest were dying. Now, this meant that we had something seriously wrong with our health systems. This has improved. I have to say we still have a long way to go, but this has improved considerably over the last 20 years. And we've been part of this improvement. And that's been a real privilege. But this level of flaws within our health system in terms of access to care was very bothersome. And you have to realize that if there is a lot of barriers to access, it also translates into very poor patient conditions. So we saw some of the most extreme cases. So here are some examples of really bad, advanced diseases with a lot of comorbidities. A lot of patients becoming inoperable with Eisenmenger syndrome. You can see this chest X-ray and fingers with clubbing. Or a lot of neurologic damage happening because of the heart disease, devastating these children. So this was the status of the specialty then. It's a little better now, but still we have a long way to go. 1997 October, Amrita Institute came into existence, and there was something different about Amrita Institute because there was a clear mandate to serve the poor. That really was very motivating and inspiring. And we had our director, Dr. Prem Nair, who's still with us, and Mr. Ron Gottsagen, who's a very inspiring personality who were at the helm of affairs. And I remember having said yes, just by meeting these people, not daunted by the fact that the building was still under construction. 1998, we established the program and we decided to write our mission statement. The first thing I did, I drafted this mission statement. I said, we have to make it accessible to the average child in the region. I came back from the US to a corporate hospital in Delhi and we were sending away children because they were falling short by 10,000 rupees. And that bothered me. Okay, if we have to be accessible, we have to be cost effective. We can't just say we want to reach out to everybody, but we have to be mindful of costs. We have to be mindful of costs, yet set the highest standards. So I set my bar at Boston Children's Hospital. It's very high. We can't just try to do it alone. We have to train and build capacity. And then research had to be integrated into all this because we're dealing with a new specialty. Not much knowledge was available within our context. So this was the agenda. This is my first student, Aarti, who's brilliant, who resonated with all this. And she's, of course, now in the US at Seattle. But with the help of her, I set up the program. And then, of course, there were many other people. So let me take you to 1999, when we had this real challenge present to us. This is a baby with a large VST. You know, the VSTs are large shunts that produce failure to thrive. This baby really was doing poorly in terms of weight gain, had lost weight, and at 6 months was 2.5 kilos. And we were confronted with this problem that nobody in the world knew how to deal with. People within the country, the pediatricians would say, you don't operate because this child is at tremendous risk. Nobody wanted to do it. The surgeons were afraid. This child's father told us, I'm not taking the baby home. I'm just tired. I've been looking after this baby for 6 months. Nothing is working. You doctors are not. So you do something, fix this child. So we jumped in and fixed the heart. We did a VSD closure. And this baby survived, and not just survived, became someone totally different 3 months later. led me to the first research question. The first research question was, does undernutrition increase the risk of VST closure? A question that had not been answered. It's very important to our context, was no longer relevant to the Western context because babies were getting fixed on time there, but was relevant to our context. So I partnered with my mentor in Harvard. I got in touch with their statistician because we didn't have statistics. We put together a database, shared it with them, and then answered the questions. What we found was, based on this very case, we found the same thing happening applicable to 100 other babies, which is that if your weight, we measured the weight by weight z-scores, which is like percentile, the ones who died versus the ones who did not die, it was no different. Neither was their heights different. Yes, what mattered was whether they were infected or not. There was a difference there. And whether they were ventilated preoperatively or not, and there was a difference, but the weights did not matter. So that changed the paradigm for us. It took a while before this idea got accepted by my colleagues elsewhere in the country, but slowly over a period of time, they accepted it. Now, once you had this data, it was very easy to ask the second question, which was, how do these babies grow? So we followed this 90 of these 100 kids for 1 year. In fact, much longer than that, 52 months, nearly 4 years. And we found that these kids did well initially. They grew very well initially, but then eventually had some level of stunting that was determined by maternal influences, by their initial weight. So if they were really, really undernourished, they lost their capacity to gain weight beyond a point. That's a very important point. So it underscored the fact that you had to correct them even earlier. And lately we found that if you correct them really early, their growth curves come back to normal, which is happening in the West. So this was fascinating and we got excited. And then we had the challenge that really killed babies with VSTs, which is pneumonia. So earlier you used to have a situation where babies with pneumonia, you would wait for the pneumonia to go away before you operated on them. And that wouldn't happen because it's just a vicious circle. So we decided that we will wait for a time period where, let's say, there is a window of opportunity. And we decided to look at that, define the criteria, and wrote that experience. And that again changed the paradigm. And this paper has been a game changer because after this, globally, the whole concept of trying to manage VSDs with pneumonia has changed. And now we don't wait. Very few people wait for the lungs to totally clear up and they're able to save these babies. So essentially, about improving outcomes, we had two fundamental situations. One was what is not in our control. Babies with undernutrition. As clinicians, we didn't have control. As public health people, you do have some potential to affect that. But as clinicians, and the baby comes to you with poor nutrition, you have no control. Those who present late, those who have infections, and our resources. To some extent, we have control, but to a large extent, we don't. The question that we asked was, how much does it matter? Then the second set of questions was, what is in our control? Quality of surgery, bringing in a cohesive team effort, something that was alien to the Indian medical environment at that time. Bringing in robust quality improvement systems. So it's always systems that really make the difference. And infection control specifically. The question we asked was, how much of a difference will it make? So we decided to embark on a series of interventions, systemic interventions to our program. One was we partnered with an overseas NGO that brought in some expertise from overseas called Children's Heart Link. Then we initiated very specific infection control initiatives. And we got in an ICU expert, the man with whom I trained in Boston, to visit us on a regular basis and monitor our ICU, an infection control expert. And then we had an infection control champion who's now known globally, Dr. Sanjeev Singh. We partnered with him. In fact, I convinced Sanjeev Singh to do a thesis on infection control as a health administrator. And that led to the establishment of the infection control unit at our hospital. Dedicated ICU. This is Dr. Rakhi, my colleague, who does a tremendous job in establishing the ICU. So we trained her and got her to establish the ICU. And then tried to record what it did. Then what was really significant is we joined an international collaborative. Prabhakar talked to you about the value of collaborations, where the sum is greater than the whole. So it's amazing how many vistas open up when you actually do a collaboration. So IQIC is a global collaborative of 59 centers in low and middle income countries that do pediatric heart surgery. We signed up for this. This allows you to benchmark your results with the rest of the world. And of course, there is a whole series of QI measures that come in. And that was a game changer again, because then we started to look at our database to answer more and more questions. And then we started to see a real tangible difference in our outcomes. We got the BMJ award, which again was a big stimulus to do more and more. And then we decided that the big factor is nursing. So we've established a nurse residency program and so on and so forth. It goes on. So essentially, the point is the clinical research and QI and day-to-day work had to be integrated one way or the other with everything else. So one of the things we did was to integrate it with our postgraduate thesis. So one thesis led to the other. And these are all examples of various theses that really looked at every aspect of trying to deliver care. And we had a postgraduate link to this. So what happened because of this? Well, it was gratifying. So we started off in 2010 at an embarrassing 9% surgical site infection rate, and we got it down rather quickly. We started off with bacterial sepsis rates that were alarmingly high, particularly newborns. Again, we got that down. And what's really interesting is that this IQIC lets you compare outcomes with the collaborator, and you're able to see how better you are with the rest. So the line at 1 tells you where it was, where the rest of the world was, and where we are in comparison. We were worse than them and became better. Similarly, our mortality trends were all very gratifying. We started off with a 4% surgical mortality. It's down to 1%, despite all the challenges we face, and our standardized mortality ratios is better than the global average. Now, this was amazingly inspiring to share with the rest of the team. So some personal insights. I think it's important to do research in context. You have to have your agenda. You can't be part of somebody else's agenda. You need to balance. And I think blending is very important. You can't look at mentally creating silos that this is my protected time, this is for research, this is for work, this is for life. It doesn't work that way. You need to integrate everything. That's the only way you can do clinical research. And then it has to be integrated into specialty development. It has to be rooted in our context. It has to seek to find answers to our most relevant questions. So if I look at my own specialty of pediatric heart care, one element is to define disease burden, deliver care, improve awareness, and then every aspect of disease can have an epidemiologic study. A whole bunch of interventions relating to delivering care in our context can be studied. Each of this can be looked at systematically. What's been really satisfying is that we've been able to address health system challenges within the state of Kerala and then eventually dramatically improve access of care through partnership with the government. Each of this, again, is a research question which can be answered very elegantly. So I think doing research means trying to understand our problems, finding answers to our challenges, checking on our intuitions. Some of us make these statements, oh, I think this is what it is, but you need data. So you need data to validate your intuitions. And ultimately, all this translates into care. What it needs is curiosity. You have to frame and articulate a question, design a study, collect the data, analyze the results, publish, but it doesn't end there. You have to persist, because the first set of publications take forever. You can see 100 rejections, but if you persist, you break the barrier, you learn how to do this. What are the barriers? You all are aware of it, but I'll articulate it for you. Conditioning in our formative years, I think, is really, really important. I've been fortunate to be conditioned by people, by mentors who really made me become passionate about research. All these are excuses, what follow. What really matters is this, is conditioning. If you're conditioned, and that's what we need to do with the vast multitude of medical students in this country. So I mean, for me, as I said, I had a tremendous atmosphere in All India Institute with Dr. Tandon, with Dr. Reddy, with so many other people who were role models, peers. The prevailing culture was so conducive to asking questions. This needs to be the norm in our medical colleges. Challenges remain. We still are very top-down. I'm very disappointed at this point. I still find all the research questions coming from the faculty, not from the students. That needs to change. We don't have electronic medical records that enable research in most hospitals, and that needs to change. It can be very powerful if you have it that way. Government grants can be a challenge, particularly in these times. And then there are publication barriers. What we write, we find it very hard to publish because there is a credibility question with Indian data, and there is a quality issue. So, and there is a bias as well. So to overcome that bias, we started our own journal, for instance. I started this journal way back more than 10 years ago. It's been quite a success story. Eventually has served as a forum, and it receives a lot of articles. Now, in fact, receives more articles from the United States than from India as well. So coming back to the question, what is the most sustainable motivation to do research? And I think it is a genuine curiosity, a desire to improve patient care, and desire to generate knowledge. Only this sustains your motivation. Everything else will sustain you, will give you motivation for some time, but cannot be a reason for you to do it every day, want to do it every day. I have to thank my department. I'm blessed. I'm at the right place at the right time with the right people. And that's why I've been able to tell you the story. Thank you.
Thank you so much, Dr. Krishna. I was honestly, like, from a personal perspective, like each and every point of the presentation, my eyes were just like stuck over the presentation all the time. And thank you so much for such a wonderful session again. We have questions from the participants. One of the questions is that how can I, as a third year medical student, start a research project during this time?
I think it's great that you've asked that question, which means you want to do it. And I've had medical students who've come to me and I've been able to mentor them. So the first thing is to find a mentor who could work with you. And there are mentors. There are people. So if you find somebody who's been particularly successful with research, who resonates, and you can go to that person and say, listen, I want to do a project. And if you're assigned a certain role, you carry out that role well, I'm sure you'll be able to then make a partnership and do something useful. What excites us as faculty is the enthusiasm that we see in medical students. The single feature that I think is essential as a student is you have to be enthusiastic. The opposite of that is cynical. And if for every enthusiastic student, you will have 20 or 25 cynical peers who will just bring you down. And the thing that Arun said at his talk, you need to be able to have that faith and belief in yourself to actually do what you're doing. And our job in this particular session is really to inspire you and say that that's a very meaningful pursuit. So do it. No question about it. Find the person, make the partnership, and go ahead.
Thank you so much, sir. The next question which we have is that teachers do shape your careers. How can someone introspect their own interest or following the subject of their mentor?
So I didn't completely understand this, but yes, it's true. Teachers shape their careers. I am doing pediatric cardiology because of Dr. Tandon. Very simple. So when you find a fantastic mentor, you want to do something very similar to that. And for a period, we had another great mentor in neurology, Dr. Ahuja, and we wanted to do neurology also. So we were confused at the end of it, but then we chose a specialty based on what the mentor told you. Each person has a different reason to choose their career. You don't exactly have to do what the mentor does. You can follow the path, but you can go to a different goal. You don't have to do exactly what the person does. That's not so important, but it's important to emulate those qualities, to understand what makes that person successful, what makes that person effective, what makes that person inspiring, and emulate those qualities.
Thank you so much, sir. That gave a lot of clarity, I'm sure, to a lot of students here. Having said that, we can proceed with the next session of this beautiful guest lecture series which we have. And I would again like to thank Dr. Krishna Kumar sir to take the session on improving clinical care through research, because I'm sure it gave a very different and an insightful perspective to a lot of students, and which is something which we highly require at this point of time. Moving ahead, the next session which we have is by Dr. Nikhil Tandon, and he'll be talking about translating research into policy. Um, Dr. Nikhil Tandon has been trained in the All India Institute of Medical Sciences and Cambridge University, and is the Vice President of the National Board of Examinations and board, member Board of Governors in the supersession of the Medical Council of India. He is an internationally renowned researcher and global expert in the implementation sciences. He has won several awards, including the Padma Shri and the B.C. Roy Award, and is also the head of the Department of Endocrinology at the All India Institute of Medical Sciences at New Delhi. Dr. Tandon, it's a pleasure to have you today with us. And over to you, and we would love for you to begin your session.
Okay, a very good morning to everybody. I managed to catch a large part of Dr. Krishna Kumar's talk, and there are going to be several similarities and several differences. And let me first try, I will need some assistance with trying to get my, sharing my screen for some reason.
So there is an option of share screen. How is it?
No, I can see that. The only problem is I'm just not, just give me a sec.
Yes, yes.
I should have been seeing more. Okay. Let's see now. Yeah.
Yes, we can see it there.
Okay. So the several similarities with what Dr. Krishna Kumar said. Now, let me get those done first. And I think it's very important to understand that there are invariably triggers for doing research. And he explained the triggers. There are also key human beings and key institutions which help shape your research career. And then there are key partners which help you take along. And that would be common to whether you're doing this in terms of creating an exceptional department of pediatric cardiology, an exceptional service for the care of people with pediatric cardiac diseases, whether you're looking at a particular ailment and managing and looking at clinical management of that, or if you see a situation that requires an intervention which even needs to go outside the space of hospitals. And what I will be therefore doing is giving you a slightly different example. And this is that sometimes research and the endpoint of research may not be restricted to a medical or a healthcare institution and may require a public health component to that. And that's where this story is going to come across. And let me just, and it says salt iodization and others. Let me reassure you, I'll stick only with salt iodization. And I'll try and do this in the time which I've been allotted with, and therefore I will skip everything else. So you would all have learned a bit about iodine deficiency disorders, and especially when we were undergraduates, we normally used to think of it in terms of the first two boxes shown above, i.e. that people with iodine deficiency disorders have a goiter, and if it happens in neonatal life during the child's in utero existence, they can end up with congenital hypothyroidism, and if that is left unattended or untreated, the child can develop cretinism. But of course, what we've understood since is that there can be a much broader spectrum of iodine deficiency disorders. It could be abortions, could be stillbirths, could be other birth defects, could be defects of speech and hearing, could be squints, could be psychomotor defects, and even more so, that it's just not severe mental handicap as manifested with cretinism, but even among school-going children who come from iodine deficient areas, there could be a reduction in IQ points, which could impact their scholastic performance. So it's a huge spectrum of disorders. And that's what we really understood over a period of time. Has this been around? It has really been around for a long period of time. And as you can see, This is a graphic or a fresco of the time of the Buddha. And if you see the box here, sorry, if you see this box, you can actually see an individual out here in which there is a neck swelling. So, and a goiter has been very much part and parcel of our existence for several millennia before even the birth of Christ. Now, I'm going to tell you the story of one individual. Obviously, the story is not that of the individual alone, but the way he harnessed resources, the way he put together a team of collaborators, the way he did so across specialties and disciplines, and the way that this effort, which went on for decades, resulted in changing the face of how we look at a public health problem like iodine deficiency. So one of the lessons you will have heard through Dr. Krishna Kumar's talk, and I'm sure other talks also, is that, you know, this research is a journey, and there are multiple steps in this journey. And sometimes the horizon is very, very far and very blurred. But you've got to take this one step at a time, and eventually you'll be able to look back in life and say that I embarked on this journey, I did incremental research, and eventually then came up with this package of solution. I mean, Dr. Krishna Kumar showed you that in terms of improving outcomes, whether it was surgical mortality, whether it's reduction in infections, this was done over a horizon of 15, 20 years. And it's a longish time for most of who are 20 years in age. So that's the other thing important, that don't expect dramatic things happening the very first time you embark on something with research. There will be small incremental gains, but you need to stay focused on your trajectory as you go along. So this is something which was published in the Bulletin of the World Health Organization by Dr. Ramalingaswamy. He, pathologist, a nutritional worker. He was also the director of the All India Institute of Medical Sciences. To the best of my recollection, between 69 and 74 or 75. So again, several years ago, unfortunately, he's no more today, but an incredibly smart human being, very articulate, very focused, and very passionate with what he did. And you can see from this map that the shaded areas here are what was considered to be the trans-Himalayan belt where goiter was manifest. Right? And if you look at these, the numbers are not really critical, but in a lot of these places, goiter was seen in between 30 and 50% of individuals who were surveyed. That's a lot of people. Now, what was responsible for this goiter? Actually, the number of theories were more than all the fingers and toes that we had. By even the late 19th century, there were more than 40 different theories which were used to explain the cause of endemic goiter. One of them was definitely iodine deficiency, but it's also hard water, fluorine, coliform organisms, etc., etc., etc. But iodine was only one significant part of this list of variables considered to be responsible for goiter. So what was the first bit of work? The first bit of work was to actually demonstrate convincingly that the real cause of a vast proportion of goiter was iodine deficiency. Now, how do you prove that? You need to be able to measure iodine in somebody. How do you do that? You need to have methods to assay stable iodine, which did not exist to the extent they were required. So that was one set of stuff which had to be done. You may have heard of something called radioactive iodine uptake, in which you give a few microcurie of radioactive iodine. Now, the principal source, the principal point where iodine is taken up is the thyroid gland, because it's an active uptake, as your physiology classes would have told you. Whatever is left then goes to the kidneys and passes out in the way of urine. So looking at radioactive iodine uptake, if you're iodine deficient, any iodine which you give to a person will be sucked in by the thyroid gland. So looking at radioactive iodine uptake was one way of demonstrating that this person was iodine deficient and was really taking up whatever iodine we gave. This was done in different parts of the country, and then the same assessments were repeated in Nepal and Sri Lanka to show a validation of these methods. To cut a very long story short, by this whole range of experiments, Dr. Ramalingaswamy and his colleagues demonstrated and inferred that patterns of iodine metabolism as they observed were consistent with the statement that iodine deficiency was responsible for endemic goiter, right? So now you had an effect, which was a goiter. You had a cause, which was iodine deficiency. what would you like to do? You'd obviously like to ensure that you take care of this goiter. And in the 50s, again, it was agreed that the cheapest and most effective means of goiter prevention, therefore, would be replacement with iodine or iodine supplementation. So that's 1953. Now, the question was, how do we give somebody iodine? And we need to give virtually everybody iodine, right? So again, over a series of experiments, it was decided that one of the things which people actually use uniformly is salt. And if we can use salt as a vehicle to deliver the iodine, it will take care of a significant public health question. People have tried bread. People have actually considered water. People have actually decided to give people iodized oil injections, but salt was perhaps the most efficient way of doing it. So fair enough. We said salt's a good vehicle, but how do we iodize the salt? Remember, in those days, most people did not use what you and I use today, which is crystalline salt, which comes with an anti-caking agent, which is free-flowing, which comes in lovely polythene packs, and it's resistant to moisture. What was basically used in those days was coarse salt, rock salt. Most of this was being produced by evaporating brine from the sea or inland saline lakes. Using this crude salt, how do we iodize it? Because these were lumps of salt, not the crystals or ground salt. There was also a considerable loss of iodine, which was lost from iodized salt, even if you did manage to iodize it. I don't know if you don't realize that salt actually is transported by the railways in large rakes. In those days, whatever salt was being produced was actually being transported in open rakes. So it was exposed to moisture, it was exposed to rain, and therefore it added to a problem. Also, because rock salt was sold in the open, people would wash salt, right? Because there were lumps of salt, they used to be washed. And in the process, if this iodization was by spraying, most of the iodization was on the surface. And if you wash that lump of salt, you actually lost iodine. So again, these are all important questions. Then what will happen if the salt is cooked, right? And we put salt in our cooking. Will that evaporate, the iodine evaporate? We didn't know the answer to that. How much should be the salt? Should we add 100 mics, 1,000 mics, a milligram, a gram in every gram of salt? We don't know. So there was a whole bunch of questions which needed answering, right? And these were all independent questions which required application of mind. Now, this was resolved over a series of experiments without going into the details of those experiments by the mid-1950s. And at that point, what Dr. Ramalingaswamy, whose photograph is shown on the slide, demonstrated using perhaps the most fascinating public health experiments in those days. Remember, we all heard of randomized controlled trials. Medical science has used them for a long time. The economists started using them much later, and Abhijit Banerjee and Esther Duflo got the Nobel Prize last year because they use RCTs to explain economic phenomena and see economic benefit. But this was all at a time when the concept of RCTs just didn't exist. So this was a really, in today's parlance, a cluster randomized trial, right? So he went to a place in what was then in Punjab, the Kangra Valley. Today, Kangra is part of Himachal Pradesh. It used to be the biggest district of Himachal then. It's now been trifurcated now. It's a smaller district, but took the Kangra Valley, divided that into three parts. The Kangra subdivision here, the Nagrota subdivision, and the Palampur subdivision. And decided that I will ensure that everybody in each of these subdivisions gets different forms of salt. Now, doing an RCT with a drug is you call people to the hospital and say you will take drug A or a placebo or a comparator drug. This was trying to ensure delivery of salt to every single human being in a subdivision of a district. That is an administratively immensely challenging issue, right? So he decided, I'm going to use, we don't know what's the best thing to iodize salt with, so we'll take either salt which contains potassium iodide, which goes to the chaps in the Kangra subdivision, and then we'll ensure that the guys in Palampur will get potassium iodide. So this was the Kangra Valley study. If you Google it, it's perhaps one of the most exceptional public health experiments known ever. Not in India, ever. It was a community-based prospective control trial. It was done over 16 years. no randomized control trial, which we think of, we do 26 weeks, we do 52 weeks, we do maybe a couple of years, 16 years, unheard of. Study population, few people, few hundred people, no, 11,000 school-age children. And the outcome variable was goiter prevalence among school-age children. The reason school-age children are taken is because when goiters develop in this age group, they are still in a situation that if they're because of iodine deficiency and you give them iodine, the goiters shrink. In adults, by the time that they have got an established goiter, even giving iodine will not cause a resolution of that goiter. So what they did was a baseline survey independently in 3 zones. Salt was distributed through what you may have never heard of, what are called ration shops, a public distribution system, salt containing potassium iodide, normal salt, and salt with potassium iodide. How much to be given? Well, maybe people take 15 grams of salt. The calculations today are based on 10 grams of salt. And the calculation was we should give enough iodine to ensure 200 mics of iodine per person per day, right? These are the 3 divisions, and I'm showing them again for you. And I will come back to this right at the very end and explain why. So potassium iodide, plain salt, potassium iodide, right? But obviously, how do you ensure that somebody gets the salt you want? You're not going house to house and giving them packets of salt. You have to ensure that anytime a person goes to buy salt, they will get the salt you want to give them. So an administrative intervention was required. Legislation which led to the ban on the sale of non-iodized salt in the study area. So if I lived in Palanpur or I lived in the Kangra subdivision and I went to a ration shop, I could only get an iodized salt, right? And the other thing which is very important, why should the consumer pay for an extra cost? Because you haven't yet proven that this salt, which is iodized, is of benefit, right? So the salt difference, actually it's a 50 paisa difference per kilogram, but even why introduce that difference for the consumer? This is information on the data from the Kangra Valley in Zone A. Baseline goiter prevalence in school-age children, 40%. 6 years later, 19%, to halved the goiter prevalence, and then a continued iodized salt, it brought down to 8%, from 40% to 8%, 1/5, right? Now that's a huge decline in goiter. You don't need to do statistics, right? You can see it there. You don't need to look at anything to say that this is beneficial. What happened in Zone B? These are the chaps who got plain salt. It was 40% to start with. It was 40% 6 years later. It became unethical to continue them with this. And then they were given potassium iodized salt, and it dropped dramatically from 40% to 15%. And then look at Zone C, again, very, very similar numbers, 40% down to 15% and down to 5%. And that was that. So very clearly, giving iodine, using salt as a vehicle, clearly diminished the prevalence of goiter. There was nothing equivocal about it. This was clear, this was stark, this was enough to drive any policy. So iodine supplementation in the form of adequately iodized salt on a regular and continuous basis reduces goiter prevalence, and therefore the recommendation was establish a national goiter control program, which was established in 1962 after the first phase of the study was done. So from the time of 1867, when there were 43 theories of what causes goiter, to 1962, right? That's 60 years to create a national goiter control program. Then came the issue of iodine deficiency in learning disabilities, and I said, besides cretinism, and this is the biggest problem, if you do a survey when you go to schools, you will only see children who are good enough to be educated in school. So the people who had significant mental handicaps will never get enrolled in schools. So there's a difference when somebody says, I did a study in school-going children, and I did a study in school-age children, right? Everybody who's in a certain age group is entitled to be going to school, and therefore to look at them, you'll need to go not only to schools, but also to the houses, because there may be a bunch of kids who are in the school age group, but not registered in schools because they've got a mental problem, right? So this was even amongst those who are school age children and going to schools, they had a 13 IQ point deficiency compared to those who lived in the iodine sufficient environment. This was work done in lots of places, including at the All India Institute of Medical Sciences. So from 1962 when a national goiter control program came into being, it was then decided 20 years down the line. Remember, another whole new cycle of medical students who were not born in 1962 and had now entered medical school. That's the lifespan of policy change. In 1983, the government of India took a policy decision to iodize all salt meant for human consumption. And therefore, from a national goiter control program, it became universal salt iodization. The other thing which really happened, and look at the amount of administrative decisions which need to be taken for a public health benefit. Till then, only the government made iodized salt. They opened it up to the private sector. And you will see the results here. So in between 1962 to 1983, when there was a national goiter control program, the number of salt iodization plants, because it was only the government who were doing that, were 12. In the next 20 years, it became 859. The production capacity was 38,000 tons. It became 12 million tons. The actual production was 15,000 tons. In 1960 to 1983, became 4 million tons, right? And the overall production in the public sector went from 100% to 2.5% because the private sector took it over 97.5. So you've got to engage with all stakeholders, right? So this was a pre-iodization era photograph. This is me, by the way, and this was, I think, in about 1997 or 98. This is just to show you, this is not supposed to be reality, but we were so iodine deficient that even the trees had goiters. But reality is, of course, that even animals have goiters. And you can see that there's a goiter in livestock. And therefore, this was not a disease restricted to humankind. This was a disease which affected livestock, which possibly affected a lot of species. And therefore, daily consumption of adequate iodized salt is required and mandatory. I'm going to come back to Nagrota with a very, very simple comment. So Nagrota, if you remember, was the middle zone, zone B, which had the misfortune of being randomized to getting the non-iodized salt. They got it 6 years later in 1962. And so you can imagine that was a place where had a 40% goiter problem. I was invited to Nagrota in 2014 as by an NGO to take part in a multi-specialty health camp. The reason for that was not because they wanted me to discuss and treat thyroid disorders, because I was invited to speak on diabetes. The problem of goiter has virtually ceased to exist or is not relevant enough to call a person who's a thyroid specialist for a talk in that region. So that's the impact of policy. It takes time. It takes effort. It takes multiple disciplines within the medical community. It takes multiple disciplines outside the medical community, but it has an impact which is enduring and much, much more significant. So I'm going to stop here. And the word context came in one of the last slides of Dr. Krishna Kumar's presentation. There was no point doing a study on onchocerciasis in India, right? It's river blindness. It happens in West Africa. Goiter was a context-specific decision. It was a problem which is plaguing our population, our community. So look out. What you see in the clinic is what you need to address. What you read in a Western textbook may be illuminating for several things, but is not the best source for you to identify a problem which is pertinent and relevant for yourself. Ask the right questions. The people flip this around to me and say, every question is right. My answer to that is yes, never be afraid of asking questions. And that's what, again, let me go back to what Dr. Krishna Kumar said. If you're brought up in an environment where you can challenge your boss, that's the environment you need to be. If you're afraid of asking questions because the environment doesn't encourage you to ask questions, you're unfortunately in the wrong place. You should be able to ask the questions. The person who's supposed to be answering them should not feel in any way intimidated or insecure in saying, well, guys, this is a great question. I don't have a clue. Let's try and find an answer together. And we grew up in that environment. Most of our bosses and most of our teachers did not have any problem in accepting that they didn't know an answer, that they were willing to look. They were willing to open a textbook and say, Let's look for this together. And so the questions need to be asked, but they need to be relevant for the problem that you're trying to answer. Focus, be persistent, and develop a very thick skin, because the likelihood of failure is much, much higher than the likelihood of success. And even for those who have success, failure is invariably the first and several of the early milestones. So be very, very thick-skinned and very persistent. Because if you think, okay, let's do a research project as a third-year medical student, as was asked, and by the time I'm a final year medical student, I have 5 papers in the Lancet, it's not going to happen, right? The other thing which is critical, and that's really not under your control, but then if you have a choice to work in different institutions and they're equally good in terms of, what is perceived by the, what is it called? League tables of today, look at where is a critical mass of researchers. I know several institutions where there are 1 or 2 exceptionally committed researchers, but they're handicapped not by the fact that they're not good researchers, that they don't have a critical mass around. As somebody, I think my introduction mentioned that I had the good fortune of actually being in Cambridge, and I'm not. So Cambridge has something called the Lab for Molecular Biology, which is a Medical Research Council lab. In 1990, when I was there, in the Lab for Molecular Biology, which is a 5 or 6 floor building, there were 5 working Nobel laureates at that point in time in one building, right? So obviously we can't replicate that, but you need a bunch of people. So you need that security that if you have a question in mind, if Dr. Krishna Kumar had a question about infection control in mind, he needed to reach out to an infection control specialist. It could be a microbiologist, which could be an internist with infection control interest, which could be a hospital administrator, but he needed to reach out to somebody who would support him. You can't do everything on your own, but you need to show commitment and passion, which you can then rub off onto others. And that's critical. You need to develop strategic relationships. Who's spoken to you since morning? I think Dr. Reddy spoke. He taught all of us on the panel. Dr. Prabhakar has been speaking. So he, Krishna Kumar, and I were residents together. So we developed strategic relationships, right? Very important. And these relationships have to endure over a period of time. And the last thing, which is very, very important, is learn to speak to each other, learn to communicate, but most importantly, learn to listen. You're not here to only tell people about what you're doing. It's actually far more important to learn from other people and hear what they're doing, because that's what's going to inform you. Once upon a time, my PhD supervisor told me, and he was very fond of me, but he told me something. He said, every time you come up with this great idea and you think you're the first one to come up, the chances are that 9 out of 10 times, it really means that you haven't done a literature survey well enough, because if you're smart enough to get an idea, there's a very good chance that somebody before you also got the same idea. You just haven't looked hard enough for it. And he wasn't being mean. He was just stating the obvious, that if you want to do something, you need to be committed, you need to listen to people, and you need to really dig deep and get this, right? And so I'm going to end here by saying that I've been blessed by a whole bunch of research collaborators, each one of whom has taught me tremendously. The story I've narrated has got nothing to do with me. I have not contributed 0.00001% to the story, but it's an inspirational story of how one man can put together a team of individuals and take a story from basic biology, basic biochemistry, nuclear medicine, nutrition, understanding the politics of policy, and then taking it to an end point such that we assume that taking iodized salt is just a natural part of life. It took a century, guys. And that's the time span for which so don't get disappointed or dejected that, I'm not going to be around 100 years from now. But he was there to see the fruition of his efforts. And we are here to bear the benefits of those efforts. But it's a great sense of being party to such journeys, even if your name is written and etched in small fonts on one of those milestones. I think you've done well in life. Thank you so much.
Thank Thank you so much, sir. It was a very elaborate session, and thank you so much for putting such a gray area of policies, which is a mystery for a lot of students, into such clear perspective. So thank you so much for again taking out the time to deliver this session with us on our platform today. Having said that, we would be moving to the next session of our um, guest lecture series right now. And the next speaker whom we have right now is Dr. Purnima Prabhakaran, who will be speaking over environment and climate change, and will be linking it to public health. Dr. Purnima, uh, Dr. Purnima Prabhakaran is a physician and is an epidemiologist by training. She's a graduate from the Bangalore Medical College and master's from the London School of Hygiene and Tropical Medicine. And she obtained her doctorate in public health from the University of Bristol. She heads the Center for Environment Health at the Public Health Foundation of India and is a well-known environmental and public health advocate. She is a leader in climate change research and currently leads several initiatives that explore its impact on health and healthcare. Thank you so much, Dr. Purnima, for joining us in this session today. And over to you. Please feel free to take the floor.
Thank you, Mauli. Good afternoon, everyone. As always, it's a delight to be talking to the younger members of the medical fraternity, and I'm grateful to MSAI for this opportunity that we have here today to connect with all of you. I'm coming at the tail end of a series of talks by stalwarts, all leaders in their own right, and I'm really glad to share that all of them have been my teachers and mentors along my career path. And I just suffice it to say that I want to start by saying a heartfelt thank you to each one of them for what they have contributed to my career. I will not be sharing my personal story here. That's another thesis by itself. I'll save it for another day. But I'm going to be talking to you today about environment and climate change. And what really bothers me today from the position that I am in today is that it is still parked as the outlier of research in public health. So if over the next few minutes, I can convince at least some of the people in the audience, and I have some converts who will agree with me that this cannot be the case anymore, and it has to occupy center stage in the discourse around research and public health, I think that'll be a job well done. So to kick us off here, I wanted to start with this perspective of a life course approach to health outcomes. You've heard a lot that has happened around research in public health from all my previous panelists, but I'm not sure that this concept of a life course approach was mentioned. So I'd really like to start with this. This speaks to the concept of experiences early in life that can influence an individual's later life health as well as disease outcomes. And this speaks to the entire concept of exposures and determinants, factors, starting right from pregnancy and factors that determine what happens during intrauterine life, and moving on through the neonatal period, infancy, childhood, and through adolescence, the number of multifactorial pieces that play together to determine what happens in later life. And believe me, this whole concept of the life course approach has been researched ad nauseum around the world for a host of health conditions. And you can see some of those that I've articulated here. And the point I want to make, and I will make it right through the presentation, is where are the environmental risks? Where does environmental factors in our lives sit within this whole discourse of research for health and disease? And I will give you, just to make that a little more clear, an example from research that happens for non-communicable diseases. And as most of you know, non-communicable diseases covers diseases, chronic respiratory diseases, mental health. And much of that research speaks to this concept of the life course approach. And just the example here is, we talk about how globalization and urbanization influences our behavior, our lifestyle, what we eat, how we move, what kind of substance abuse happens. I've missed tobacco here, I've missed alcohol here, and how that kind of plays together to influence a lot of health outcomes in later life, and the morbidity and mortality from these conditions. Of course, there's a lot of research. We've heard a lot about the system challenges. What kind of healthcare is then available to these people? What determines access to care? What about the quality of care? There's also the whole concept of genetics and fetal programming that has been researched in relation to all of these conditions. There's poverty, there's education, stress, there's life course socioeconomic status, all of which are conditioning factors in determining these health outcomes. So what happened to the discourse around environmental risks? For the longest time, these risk factors were never thought about. Air and water pollution, changing temperatures and rainfall patterns, land use changes, our built environment. How do those factors determine any of these health outcomes? Deforestation, and collectively, all of these are responsible for climate change. I'm sure there's not a single person in the audience who heard the discourse around climate change. It's becoming a huge issue around public health, and that will become a little clearer by the end of this presentation. So why were we not talking about environmental factors, given the fact that the from intrauterine life, what the mother breathes, what the mother eats, and what happens from the first breath. We literally breathe polluted air every. So why was this not researched in like at least 2 decades before? This was not the case, and that's the point that I want to make to you. We talked about what areas to research in public health. I saw questions on muscular dystrophy. I heard somebody say, or I don't know if it was Arun, asked the question, how environmental health is such a boring topic within our department in preventive and social medicine course in medical school. But let me tell you that this is probably the most exciting discipline to be working in. I chanced upon it by accident, but I am completely engulfed in a whirlpool of action now around this topic. So here's where we start discussing actually the environment and health. So there's increasing awareness that health and the environment in which we live are linked. In 2006, WHO had estimated that a quarter of the global burden of disease was due to environmental factors. And importantly, note here that most of these are modifiable. Most of these are man-made in origin, what we label as the anthropogenic causes of disease. And that is an important point to note when we talk about prevention and implementation of programs to address these risk factors. The burden of disease in children that is attributed to environmental factors was much higher at 36%. And no surprise there, environmental burden is greater in the developing world. What are the types of pollution or environmental risks that we need to be talking about? So within the household, there's several sources of pollution. We're not just talking about the indoor air quality, but a whole host of chemical toxins that could be in the air from household products that we use. There's ambient air pollution, there's water pollution, which could then get into the marine ecosystems and then into the food systems. Soil pollution, again, which we could have pollutants leaching into our food chain. We have occupational risks, we have lead and other chemical pollutants that come out of industrial activity. So there's a host of environmental risks that we should be thinking about in relation to disease in all of our lives. This is just a heat map that I thought was pertinent to show you. This is deaths attributable to environmental risks, data from 2016, looking at all ages and both genders. And the ominous statistic here that a quarter of the deaths in the world from environmental risks actually occur in India. A huge number of deaths from environmental risk factors. And if you take that down to the national level, within India, every state is vulnerable. The risk factors may be different, but every state is vulnerable to health impacts of environmental risks. And I want to walk you through the next few slides on talking about air pollution. We've heard about diabetes, and not so long ago, India was known as the diabetes capital of the world. But today, we are known as the air pollution capital of the world. And New Delhi, our capital city, has become the poster child for everybody from the to environmental researchers about the pollution levels, the deteriorating. WHO has now said that at least 15 of the 20 most polluted cities in the world are in India. And ambient air pollution kills about 4 million people per year worldwide. Why is that important to us? Again, if you look at this heat map, you will see that's attributable to air pollution, all ages, both genders. This is again a statistic that should worry us. 17% of total deaths that occur in India. Same story, if you look at the state-wise statistics, you see that every state is vulnerable to mortality from exposure to poor air quality. And I just want to capture your attention over here. This is a change over 15 years. You see this picture here on the map in 1998, and this is in 2016. And you will see that over a period of 15 years, from just the small part, the Indo-Gangetic plain that was really experiencing toxic levels of air pollutants, we now have almost the entire country in the danger zone. We have average air quality, which is measured by what we call the particulate matter, is really high in every state across the country. And if we go by the WHO guidelines, 99% of the districts in India exceed the WHO levels, the mandated levels of air quality. And if we follow the less stringent national ambient air quality standards, we still have 60% of our districts having poor air quality. So somber scene over there, and we really need to sit up and take notice as not just health researchers, but also as clinical practitioners. We are also cognizant of the fact that air pollution has seasonal variation. There is also regional variation. So we should be cognizant of the fact as practitioners that the health burden varies with the region. It also varies with the time of the year. And what are these sources of air pollution? It's important for us to note when we talk about prevention. As public health advocates, we always talk about what could have been prevented. And here are the sources of particulate matter air pollution. We have vehicular pollution. We have these power plants that are using coal, the combustion of fossil fuels. We are still very dependent in India on fossil fuel combustion for our electricity. 70% of our electricity still comes from the coal-fired thermal power plants. And this is an important source of not just air pollution, but also climate pollutants. We have these dump sites, huge landfill sites in probably every other city, and these are another source of pollutants in the air. And not to forget natural sources that are beyond our control, like forest fires and volcanoes spewing pollutants into the air. I wanted to call your attention also to this figure here on the map of India, which shows the 24-hour average kitchen area concentration of particulate matter. And again, a very somber scene with every state in India having high levels of PM 2.5 within the households in the kitchen, which means that vulnerability is highest in the primary caregivers, the women, and often with the children around them. We are exposing them to high levels of toxic pollutants. This is data actually from 2013. Things might have changed because we've had national programs, the Pradhan Mantri Ujjwal Yojana, which sought to dispense clean cooking fuels, but we are still facing challenges in implementation, uptake, and sustaining such programs. And why is household air pollution important? This is another major killer. Kills almost 3 million people around the world every year. The open fire cooking stoves produce heavy smoke containing fine particles, carbon monoxide, polycyclomatic aromatic hydrocarbons, and dioxins and pesticides from crop residue that are used often as cooking fuels. And most of this is maximally inhaled during the cooking practice. And here is a picture of a young child. This is not a surprise. There are lots of children in our rural parts of the country that are also exposed to the pollutants from household cooking fuel. This is just to give you a perspective on what the air pollutants really do. The picture here at the center is the hair follicle. Our human hair has a diameter of 50 to 70 microns. Contrast this with fine beach sand, which is about 90 microns in diameter. The particulate matter that we talk about as a big component of polluted air in our country and elsewhere is the particulate matter 10, designated as 10 because of the size, is 1/5 of the size of the human hair. And this includes dust, pollen, and mold. PM 2.5, which is the measurement that is done by our monitoring stations around the country, along with the PM10, includes combustion particles, organic compounds, and heavy metals. And this is even tinier, less than 2.5 microns in size. So no surprises there when I'm telling you that why this PM 2.5 particle is such an important factor in determining health. And when we talk about health, intuitively, people think it is the impacts on the respiratory system. Particulate matter is very easily inhaled through our nostrils and reaches the lowest parts of the respiratory system and causing respiratory impacts. But here is what is really true. Air pollution affects multiple organs immediately as well as in the long term. So it affects the lungs. There's not too much surprise over there, but it also affects the heart, the cardiovascular system, and it's now labeled as one of the top risk factors, even by the WHO, one of the top 5 risk factors for non-communicable diseases. Causes stroke, it causes changes in blood pressure, which lead to all these outcomes. But importantly, we also will have intergenerational effects of poor air quality because it impacts reproductive health outcomes. It affects the birth weight, it affects the gestational period. Intrauterine growth retardation has been documented. It also affects fertility. So huge cause for concern there. Air pollution is not just impacting our respiratory health, but in fact, it impacts every system in the body. And this is, I will not go into the details of it, but if anybody is wondering why is air pollution a risk for cardiovascular disease, here is the pathogenetic pathway. PM 2.5 has been established to affect endothelial dysfunction. It causes inflammation. It increases the blood pressure and causes abnormalities of heart rhythm, leads to all these intermediate risks of metabolic abnormalities, atherosclerosis, arrhythmias, and LV dysfunction, resulting in these various outcomes: ischemic heart disease, peripheral vascular disease, congestive heart failure, arrhythmias, and sudden death. So as much as we are taught about tobacco as a risk factor for all of these conditions, air pollution is really the new tobacco. So it's important for us to recognize that. It is important for us to be aware and introduce that in our practice when we see our patients. We need to have a preventive role over here as well in giving advice to our patients about protecting themselves from exposure to high levels of pollutants in the air. I want to move the conversation a bit here to climate change and why climate change. All of the pollutants that cause deteriorating air quality are also responsible for changing climate. There's a very close, intricate link between air pollution and climate change, and there's a co-benefit of addressing these two important problems together. And again, a statistic there for you: India is 14th most climate change affected country in the world. It could cost us dearly in terms of economic outcomes, 2.8% of our GDP, and the living standards of nearly half the country's population can be depressed by 2050. That's a very morbid statistic for us to understand and take notice of. And why should we be thinking about it? Why are doctors and clinicians and public health activists important? Why is this an important factor for them? The reason being, this is a heat map. The carbon emissions actually are probably more from the developed countries of the world, but there's an inequitable distribution of the consequences on health. And you can see here very clearly that it is the developing countries that are most likely to face the consequences of climate change. And that is why it's important for us here, sitting here in India, to be recognized. Cannot be a policy change like the story of iodine and goiter. Climate change is now an existential threat, and the ramifications on health are huge and important and urgent. And this is just a graphic to show you how it can impact health. Increasing carbon dioxide levels, rising temperatures, more extreme weather events. We are seeing floods, we are seeing droughts, we are seeing poor air quality. And an important factor that's often missed out is the impacts on our water reserves. It's a looming threat that's happening behind us. We are all engulfed by the pandemic. We're all engulfed by conversations around air pollution, but a huge problem that is looming ahead is the impacts on water quality and how that translates into impacts on health. You can see changes in vector ecology, the increase in water-related diseases. There's increasing number of heat waves that are happening every year. And an important impact of climate change has been forced migration and civil conflict. If climate change is going to impact health, it's also going to impact our livelihoods. And there's going to be huge conflict, not just for food, for livelihoods, but also loss of jobs and income. And this is just, again, the same story. We will see impacts of air pollution. We will see impacts of temperature-related illness, extreme weather events, water and foodborne diseases, vector-borne and rodent-borne diseases, effects of food and water shortages. And this is something that I want to talk to you a little bit more about when I present this slide here, which is WHO's statement on the 5 major health impacts of climate change. Malnutrition. As an agrarian economy, you will all understand that increasing temperature can affect crop production. Our whole food security is at threat. And given the quick turnaround time of crop maturation, we're also going to be facing nutrition security. Our crops' nutrient quality is going to be affected. And for a country like India, where undernutrition still is a problem, we're going to be faced with a double whammy of people who are affected by food security moving to the consumption of processed foods and fueling the epidemic of obesity. And the 3 pandemics, in a sense, of undernutrition, obesity, and climate change are together labeled today as a global syndemic that is of importance to be addressed, especially in a developing country like India. We also have deaths and injuries that are caused by storms and floods, the outbreak of waterborne diseases like cholera that I mentioned, and a whole new space of mental health disorders, post-traumatic stress disorders, anxiety, depression, the gamut of mental disorders that can come out of acute climatic events that are happening every year, every month. We see stories of floods and droughts in different parts of the country. Water scarcity and contamination that I mentioned already, heat waves. We are seeing increasing numbers of heat waves. Heat waves are increasing not just in numbers, but also in terms of duration and in terms of frequency. They're occurring more often in many parts of the country. And the direct and indirect effects of heat waves are on not just the immediate effects of heat exhaustion, syncope, and stroke, affecting labor classes of our population, but also exacerbation of cardiovascular and respiratory illnesses. And lastly, the vector-borne diseases. The changing temperature makes it more convenient for vectors to transmit disease. There's change in their capacity to transmit the disease. There's change in their transmission windows. And no surprise that now we are seeing these vector-borne diseases like malaria, dengue, chikungunya in regions of the country that had never seen it before. We are seeing it in the Northeast. We are seeing it in the Himalayan regions. And that is an important fact to know. And just to stress over here the importance of the water table, we are actually a water stress country. We have less than 1,700 cubic meter of water per person per year. And this owns heat waves that I mentioned earlier. This is also an increasingly common phenomena. This is data from the city of Ahmedabad in 2010, where within a period of 1 month, May 2010, we saw a little over 1,300 deaths, and 800 of them occurred in a single week here from May 20th to 27th. So again, an important consequence of climate change. I've already mentioned the vector disease links, but just wanted to highlight this one here on the zoonotic diseases. Increasingly, the discourse around the blurring of boundaries in ecosystems and the human-animal interface and jump from animal to human species, which could also be related back to climate change and the deforestation and change in land use and the pandemic that we are facing today. We are not sitting pretty on all of these facts. There's increased awareness. Governments are requesting international support. We have 193 countries that have called for action on health and climate change. We have national adaptation plans. And we in India are also working with the government on the National Program for Climate Change and Health, talking about the concept of climate smart healthcare. And I thought it's important for the students to hear about this concept of resilience of the healthcare system in preparing for climate change, as well as reducing our own footprint as a decarbonized health system. So I hope that gives you a snapshot and a bird's eye view of the impacts of climate change on health. I will end with this statement in 2018. Never before in human history have we been so forward, but never before in human history have we been so forearmed with the knowledge and tools to alter the course of that destiny. And this was a statement none other than by Dr. Srinath Reddy, our president of the Public Health Foundation of India, in a keynote speech 2 years ago at a global climate and health forum, a clarion call for action around climate change. So just to summarize, climate change is not just a challenge, it's also an opportunity. There's worrying trends of disease rise and spread. Developing countries are most vulnerable. We have poor public health infrastructure to handle this growing burden. And I want to end with a question to you. What can you do? I'll stop there. That's the end of my presentation. Thank you for listening in.
Thank you so much, Dr. Purnima. Thank you so much for linking two highly vital entities of climate change and health, and interlinking and portraying us in a beautiful manner to us. With this, I would like to say that we come to the end of the first half of our session today, which had a beautiful series of guest lectures. Now we'll be moving on to a panel discussion by subject matter experts and medical students on making of the 21st century physician. For the same, I would like to hand it over to Dr. Krishna Kumar, who will be moderating the entire panel. And Dr. Krishna Kumar, over to you.
You're on mute.
Thank you, Mauli. I think without too much delay, we'll move on to the panel discussion. But before I start, I want to tell you that we are a little ahead, we're a little behind time. So we are at 12:30 right now. Mauli, is it okay to run this session till about 1:15?
Yes, sir. That'll be all right.
Okay. So without further delay, I'll just quickly introduce the newer members who have joined the panel. This panel discussion will have Dr. Reddy, of course, who will be there, and you've been introduced to him. But I would have to introduce a few more people. One very special member who brings in a very fresh perspective to this panel is Dr. Pratima Murthy, who's the head of psychiatry department at NIMHANS. This is the oldest and the largest postgraduate psychiatry department in the country, but she comes with many skills that will appeal to the students, she is the leading mental health advocate, avid quizzer, a very popular teacher. And she's especially interested in addiction management, postgraduate training, history of psychiatry, and forensic psychiatry. Lots of very exciting areas. Along with her are is Nazneen, who needs to be introduced to the session. Nazneen Ali is a researcher at the Center for Chronic Disease Control and is a physician by training and a recent graduate from the School of Public Health in Columbia University, New York. And she is interested in health policy and management, and she works with us right now. We have two members from the MSAI, the current president of the MSAI, Purva Prabha Patil, and we're very delighted that you've joined us, Purva. And she's got lots of extraordinary accomplishments, but what strikes me is that she's a TEDx speaker, is one of the youngest TEDx speakers that I have come across at 21. She's worked on a whole variety of areas, which includes mental health, planetary health. She's been awarded the Women of the Future Award and the Indian Health Professional Award for her work. Dr. Adit Desai is the former president of MSAI, who is right now working as a managing director at the hospital in Ahmedabad, the KD hospital. And he has, to his credit, some remarkable public health initiatives. He worked and participated at the Kumbh Mela along with the Harvard School of Public Health in an individual capacity, and he carried out data surveillance and documentation during the outbreaks that happened there. He brings, both Purva and Adit bring with them a very rich level of experience that would hopefully make this panel discussion really interesting. So quickly, I had listed a number of questions, but I wouldn't spend too much time in dwelling upon the specifics of this panel discussion. Before we start, I just ask Nazneen to quickly give us a pace setter talk, which will set the stage, hopefully, for this panel discussion. And then we would try and spend the next 40 minutes or so in getting the, in discussing some very important questions. Nazneen, all yours.
Thank you so much, sir. First of all, good afternoon, everyone. It's my pleasure to be part of MedFest 2020, and I'm honored to be in a panel with such distinguished speakers. Today, I'm going to speak to you, rather give you a pace setter talk before to our panel discussion, like Dr. KK mentioned. And I'm going to briefly walk you through what it takes, or what it should take to become a 21st century physician. So before getting deep into my topic, I'd like to take you back a few years in 2009, when I was a medical student. And like many of you, I had to learn these 3 images presented in front of you. And I don't know about all of you, but back then, these images gave me nightmares. And in fact, when I think about it now, there's also some amount of post-traumatic stress involved. But I guess when, more importantly, when I asked the question of how did I learn all these facts, I mean, definitely there was the pressure of university exams, and these are the foundations of becoming a medical doctor. But more importantly, when I asked the question of how essential are these facts for an average practicing physician, is what motivated me to further research this topic. During the course of my research, one name that constantly popped up was that of Abraham Flexner. And Flexner is considered to be a visionary in the field of education. He's more relevant in the field of medical education because it was his report of 1910 that established the biomedical sciences as the foundation of medical education. However, 15 years after his own report, Flexner realized that there was too much precedence to the scientific aspects of medicine rather than the social and cultural aspects. And that's where various alterations have been made worldwide to the curriculum over the years, the biggest example being the inclusion of preventive and social medicine. But despite all these changes, the medical education system still falls short, or rather we medical graduates still fall short in meeting the needs of the society. And that brings us to the question of what are the current healthcare needs of the society. Very broadly put, it is care that is of high quality, it's accessible, affordable, and compassionate care. It does look very simple on paper, but we all know in the battleground that it's more complex than this. Different communities have different expectations. Sometimes the expectations are too high or sometimes even unreasonable. And it is for the same fact that medical students need to be trained in competencies and skills just beyond scientific content. So what are these competencies and skills? Well, there are many, but I'd like to highlight a few important ones. To start off with, I think we medical students are minimally exposed to the management, legal, and humanistic aspects of healthcare. To cite a few examples, I think now more than ever, we've realized that physicians have to step up as leaders in coordinating emergency responses and also otherwise conduct program planning and project management, especially at the primary care and resource limited settings. Coming to the legal aspects, we have very limited knowledge on how to handle malpractice lawsuits, which is quite evident in the headlines surrounding violence against medical doctors and so on. Looking ahead, or rather the present, we're all seeing how actively technology is disrupting the field of healthcare. And I feel we as medical doctors struggle to catch up with these innovations. Another very important area that we often neglect is the humanistic and effective domains of medical education. And these include putting yourself in the place of a patient and being empathetic towards them in breaking bad news or uncertainty. Drawing from the example of the pandemic again, today doctors are required to come up and speak to the public and also communicate to the media about health information and translate it to a language that is understood by all. Not only are we required to speak, we also have to know how to understand, read, and publish literature. With the same regard, we need to know how to write impactfully. And lastly, also frame research questions and use statistical tools to not only be content consumers, rather to be content generators. So now that I have listed the deficiencies we as medical graduates possess, what is the way forward? I feel that we need to be made available these competencies and skills in parallel with our medical education to training and capacity building with a focus on competency-based medical education with relevant and flexible content. And most importantly, I think going back to Dr. Krishnakumar's talk of the importance of a mentor, I think that should be made available to us very early on in our careers, especially as medical students. And also the opportunity to network with students all around the world to see where we stand. This does sound ambitious, but what is the best way possible to do this? Recognizing that we as medical students are stretched thin and we often have the burden of coursework, I think the best way forward is to be made available an innovative platform which is self-paced or instructor-guided through an e-learning module. And why I say this is because the future of learning looks more digital now more than ever, because the biggest example being how we're conducting this MedFest through Zoom. So having said that, what should this innovative platform contain? And what are the things that should be focused on? I guess to round it all up, I feel like these 6 areas should definitely be addressed. And these include managerial organizational behavior and crisis management, health law, ethics and policies, healthcare innovation and technology, professional and personal development for career building and also to address issues like burnout, research and knowledge translation, and lastly, communication, empathy, and cultural competency training to address issues surrounding race, caste, gender, etc. Lastly, going back to my first slide with the Krebs cycle and my question of how essential are these facts? Of course, those facts are essential, but I think it needs to be augmented and complemented with the competencies and skills I mentioned above to create 21st century physicians who are effective communicators, social entrepreneurs, generators of knowledge, and also leaders, not at the national level, but at a global level. I'd like to end my talk with a quote from Dr. Alvin Toffler, who said that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. I now hand over the stage to Dr. Krishna Kumar to initiate the panel discussion. Thank you so much.
You're on mute.
Thank you, Nazneen. That's set the stage quite well. I would like the panelists to unmute their mics. Dr. Pratima, I can see you, so you can unmute your mic, and that's Purva, right? So that's fantastic. And I can see Adit as well. Wonderful. So I'll start off with the first question that we had outlined for the panelists. I think the first question, which I've will be directed to Purva and to Adit in that order, And then we will have the faculty come in as well after that. And I'll ask Dr. Pratima to give her views. So the question here is, how do we generate knowledge that is relevant to our context and apply it to our patients? It's a very broad question, and a lot of it was covered during the lectures, but maybe let's try and get an undergraduate perspective, Purva.
All right, thank you for the question, sir. I do have to admit that it's very difficult to answer this given that there's very less time. But and also, I don't intend to sound like I'm ranting, but I think before jumping on to generating knowledge, what's important to discuss is how do we stop penalizing people who have some amount of curiosity left? How do we stop forcing medical students in a way to be complacent? It almost feels like because I got admission in MBBS and because, like every year I see some part of my curiosity dying, like I know that some part of my curiosity and thought process is murdered. Why is it that I feel obligated to not think out of the box or not think of health systems at large, for example, or not think of anything outside of what the clinical knowledge I've been taught? And I think it's important to address these questions. And also then talk about what do we do to generate curiosity and generate these thoughts. And to answer that part of the question, I think first and foremost is creating a culture where you feel comfortable sharing ideas or thoughts or asking questions. And because a lot of times I've asked questions which I don't know why have always elicited a response. This is not going to help you be a good clinician. And it's always a internal battle for me to figure out how is it that knowing my health system a little better or understanding my health system with from a broader lens, how does that make me a less competent or a not nice clinician, if not a better one? So I think in terms of knowledge generation, what's the most important from my vantage point is to create an atmosphere, not only from the faculty side or from the administration side, but also from the student side. How do we develop this culture where we don't call somebody out because they're talking about something that does not seem very relevant to us in this moment. And also to not respond by saying ask relevant questions, because I don't see how questioning health systems in a clinical class is not relevant.
Adit, do you have anything to add to what Purva has said?
Yes, so to answer your question simply, I would say the system in India is set in such a way that students are only meant to answer, but not question. We are trained right from the undergraduate days to focus on the answers. And that is at the core of not just medical education system, but education system in general. And the culture of asking questions has to manifest from teachers and institutions for it to be accepted easily and quickly. And the biggest fear among students that all of us have seen before asking any question is, what will people think, or will this question make me look stupid? And this fear exists because of all the stakeholders, be it students, teacher, and institutes. We are the ones to blame. Asking questions has never been encouraged, and the focus should be shifted from answering to questioning, because curiosity will manifest the eagerness to learn. And the teachers and senior colleagues should encourage students to ask questions and push them in a direction where they start to think parallelly. Because just by thinking of asking a question, a student is already starting to think of multiple possibilities of that question and what it can lead to. This will eventually start a chain reaction in the student's mind. And that will propel the students towards healthy and constructive thinking, which in turn will lead to groundbreaking discoveries. Questions should not just be acknowledged by a system, but should also be rewarded and appreciated in front of everyone so that others gain the confidence of asking. And not all questions need have an answer, but all questions will help the students to think and learn something that he or she would never have otherwise. So that's my thought on it.
I'll take Dr. Pratima's views on this. A perspective, certainly welcome to the panel, Dr. Pratima. It's an absolute honor to have you.
Thank you very much. It's a great pleasure to be here. I was just listening to the last three perspectives we have from Nazneen and Purva Prabha and Adit. I mean, I couldn't agree more with them. And I stride both these sides, and I'll tell you why. I was particularly fascinated by what Nazneen said in terms of quoting Toffler, in terms of learning, unlearning, and relearning. And I think as teachers, the teachers of medicine first need to be able to do that. Because unless we kind of change our pedagogic system, I think it's very, very difficult to understand and appreciate some of these concerns that they had. Now, in my own institution, we encourage exactly the things that you're talking about: competency-based learning, asking questions, not really accepting anything that is told, but questioning it. For our own faculty who go back and check and say, all right, you're right. And we not only question what teachers tell us, but also the guidelines that are available for various treatments, etc. But at the same time, I see my young daughter, who's an intern, just fresh out of medical college, and she faces exactly the things that you're talking about. Answer, don't question. Think very conservatively, think of what's available. Do not look for resources beyond what you have. So I absolutely agree that I think unless we encourage people to think, to question, complacency sets in. And we want the next generation of doctors to really, step out of this complacency, address their curiosity, broaden their lens. And that's where, for example, I find that some institutions which have the applied teaching methods, which don't just teach a single subject of biochemistry, but for example, if you were talking about liver function, bring in clinicians, bring in the pharmacology department, bring in the epidemiology department, the psychiatry department to teach this. And I think that kind of broad-based knowledge is really what is going to be useful. The other thing is whether it's got to be learner-led learning or teacher-led teaching. I remember one of the earliest papers I was involved in as a resident was on this particular topic. And I think there's a lot to be said about learner-led learning, which is much more lasting, much more fun, stays with you for a lifetime, and engages the teacher in a much more, equitable manner. I don't think forever that, students cannot learn from teachers. I mean, I think teachers are amazing, mentors are amazing in the fact that they don't just spoon feed you, but they teach you the art of discovering knowledge and enjoying knowledge and applying knowledge. And I think that would be the values of a good teacher. And I hope our system orients itself to looking at this kind of a teaching rather than just a didactic kind of teaching. Technology now allows, technology comes with its challenges. Technology allows you to do a lot of wonderful things in terms of pedagogy and teaching methods, but it also gives you a lot of stuff that you have to kind of sift through in being able to reach the real stuff. So I think there are both opportunities and challenges that we have in terms of changing our learning methods.
Thank you, Pratima. I have an apology. I owe an apology to Omnia. We have a very distinguished guest from overseas, from Egypt, Dr. Omnia El Omrani. She is from Egypt, and she's the representative of the International Medical Students Federation, and she's a liaison officer there. Welcome, Omnia, and my apologies once again for not mentioning your name in the beginning of the panel discussion. We'll really value your presence in this panel. So my second question, yes.
Yes, I was saying no worries at all, and thank you for having me. It's my pleasure.
So my second question is, by the way, Omnia, we will ask you international perspective, in your own perspective from Egypt. I'm sure you'll relate to a lot of what is being said also, and you will also have differences. Well, the second question I have is, are we training our medical students to be vigilant observers of the health system? We have serious deficiencies in our health systems, which relate to every specialty, and yes, all of us are affected by it. So my question is to Purva, to Adit, and perhaps to Omnia as well. We can give perspectives, and then I'll have Dr. Reddy chime in at the end. So Purva, what are your perspectives on the fact that our education doesn't sensitize us enough about our own deficiencies, health system deficiencies? We tend to brush it under the carpet sometimes.
I'm not even going to try and be diplomatic or soft about my thoughts here. It's a big no. We don't understand our own health systems. All we understand is this is a patient, these are the symptoms, this is the medication we can offer, this is the treatment regime, and the patient goes back. We have no idea whether or not the patient is capable of, is in a position to get that sort of treatment. Some doctors to a great degree try and accommodate some sort of financial conditions attached to treatments, and be like, okay, you must probably prescribe drugs that cost lower, etc. But is that enough? Is that enough understanding of our health systems or of the entire healthcare process, and not just after the patient comes? I don't understand when our responsibilities shifted to leaving everything outside of our cabin and only addressing what's in our cabin. Like, when did that happen? I'm very seriously wanting to know. But yes, I would say even as a medical student, I don't think there are a lot of opportunities that inherently exist for me to understand the health system. But yeah, there are opportunities to understand this once I break my head a lot. And get a few rejections from a few people on, you're talking irrelevant stuff, just go, don't disturb us. For example, I remember very vividly this one particular posting that I was in. And so I knew that there was an insurance scheme for people for below poverty line patients. So I was trying to follow up on what happens to these patients after their first consultation, after they've told that they need a surgery. And I realized that a lot of them weren't showing back. And so I went to the resident and I asked the resident, what happens, because you ask them to go and avail these documents to come back with all of them and they don't come back. What is happening with that? And that's not our business. And I think that really stayed with me and even still stays with me. How is that not our business? How is patients not even making it to our doorstep not our business? So I think when I talk to my colleagues about it, a lot of them just say, you're thinking too much. And my thought process is, I think everybody should think this much, at least, if not more. So I can very confidently say that our medical education or even what we are taught on a college level or sub-college level is not enough in terms of making us vigilant and fully rounded doctors or health professionals, and that's a lacuna that I've been ranting about for 3 years now. But yes, I think my answer is a very straight no, sir.
Purva, I'm enjoying your rant. So can we ask Adit, who's now moved to the other side? You have moved to becoming an health administrator.
I completely agree.
How do you relate to it?
To add on to it, I would say like undergraduate and postgraduate students are quite smart and aware these days. And the problems in the healthcare system have always been right in our faces. Problems have been identified long back, but it is the unwillingness of institutes and the government to do anything about it. Every medical student more or less is aware of the problems within the system and also the solutions. But those solutions also need the support of government and appropriate authorities. The system has never focused on creating and encouraging leaders or to develop that thought process of leadership. It has always focused on the curriculum part, whereas it should also focus on developing character and developing the thought process of medical professionals. An ideal doctor would be the one not just with the knowledge of the subject, but also the one who thinks for the healthcare system, the patients, and has the capability of coming up with effective and viable solutions for the issues at hand.
I'll ask Dr. Reddy first, then I'll come to Omnia after this, because I'll ask Omnia her views on the first two questions. But right now, I really want to hear Dr. Reddy as to what are your perceptions on what Purva and Adit have been telling, and what are the remedies?
Well, clearly a medical student is often, sorry. Is it okay? Yeah.
Yes, yes.
Okay, clearly a medical student is quite overwhelmed in terms of the kind of things that they're asked to do in terms of their studies and training. But unless they understand the context, they will not only practice incomplete and inappropriate medicine now, but their ability to practice good medicine in the future is going to be substantially imperiled. So they have to act as change makers in order to address the flaws in the health system so that they can actually practice better medicine when they are actually going to be leading their careers in the future. Clearly, questions like, why did this person come so late in the natural history of disease? Why couldn't it have been detected earlier? If not even prevented, at least detected earlier and referred earlier. These are questions that come up all the time in the mind. Secondly, why is it that these patients are unable to afford medicines? Why is the adherence to prescribed medicine so poor? Is it behavioral? Is it financial? I think these questions are important to address. Otherwise, if we continue to neglect the state of the health system, we'll be practicing incomplete and inappropriate medicine for the rest of our careers. I think that is what should be bothering the medical students. And they may not be able to do it individually, but they have to do it collectively. And I think that is where they have to discuss some of these issues from the social perspective, from the health system perspective. As Nobel laureate Toni Morrison said, if we do not create the future, the present extends itself. Therefore, you cannot be passive observers of things that are going wrong. You have to become active agents of change. It doesn't have to be necessarily in terms of voicing grievances as individuals and grumbling about it and then going out and forgetting about it. You have to do something collectively. See, for example, if there are patients who are very upset with the way the health system is functioning and they resort to violence against the doctors are actually the victims of a poor health system. They are paying for poor organization of services. So it's not just enough to say we need better police protection. It is important also to change the system in which you're functioning, and unwittingly you're being held guilty of the failures of the system. Therefore, both in terms of personal protection, but also in terms of ensuring that you're practicing the right kind of medicine, you have to really start addressing the flaws in the system collectively. Individuals can articulate the problems, but they are unlikely to become change makers entirely on their own. So they have to motivate others and then become change agents collectively. Thank you.
So am I hearing a hidden message here that you are recommending that medical students become advocates, if not activists, in terms of trying to make changes in the health systems and not see themselves as a separate entity from the government, from institutions?
Change is not going to come in from passive observers and unprotesting victims. It is going to come when people actually recognize the flaws. You don't have to be impolite, but you have to be persistent in your demands for change. You have to come up with suggested solutions, not just a grievance list, and press for them. Unless that happens, you're not going to see change come on its own. Again, to quote Martin Luther King, he said, change does not roll in on the wheels of inevitability. You have to organize, you have to protest, you have to demand change, and you can do that as persuasively as possible if you're organized.
So here's an agenda for the Medical Students Association of India and perhaps internationally as well. So Omnia, do you resonate or relate to what's been said so far?
Yes, I think this was the perfect transition to what I wanted to say, because I would like to share from an international student perspective, because in IFMSA, we represent more than 1.3 million medical students worldwide. And one of our main priorities on areas of work that we really focus on is integrating public health and improving the knowledge that we have in medical education. And the way that we do that is that we have developed a global survey in which we assessed how certain topics were mentioned or were not mentioned in the curriculum. So for example, one of the my very issues that I'm most passionate about, and also Dr. Purnima has shared a lot about, which was climate change and health. And we had a survey that assessed whether climate change was mentioned in the curriculum or not. And we spanned over 112 countries, and we discovered that only 15% of these countries had a mention of climate change in the curriculum. So this really showed that there is a gap between the inclusion of many public health issues and our medical education. So to answer the second question, I believe that our medical education still has a long way to go in terms of really preparing us to understand our health systems, as well as many different determinants of health that impact the future and the health outcomes of our patients. And as future healthcare professionals, our duty of care does not just lie to our patients, but it also lies to our communities, which still our medical education is insufficient to help us in. So this is why I want to also highlight and get back to how we are change agents. And this is what IFMSA has also been doing. It has been really equipping medical students to engage and become meaningfully part of their own curriculum, their own education, and also by creating capacity building opportunities for them to learn outside their medical schools. So for example, I personally learned about health systems through IFMSA, through working with a group of IFMSA members from all our 5 regions and analyzing the different health systems of countries around the world, being inspired from how healthcare systems are developed in some countries, are less developed in others, and so on. So it's really important to highlight the role of medical students, of us, to improve our own medical education, to provide opportunities through peer education and inspiring our other colleagues to learn about the topics outside their own medical education and possibly integrate it on their own. And that is what I also try to do in my own faculty by working with my own public health department in Egypt and working with them on improving our own curriculum. So we can also actively approach our professors and demand better knowledge and stronger competencies in our own curriculum.
So Purva and Adit, I think I have an action item for MSAI. MSAI should find a way to be a voice in future medical curriculum designing. We've got to figure out how that happens. I don't know if Nikhil is listening, but we got to find a way to have medical students have a voice in the way curriculums are made. So that's something for your future. Now I'll quickly go on to another question, which is barriers to research. You've listened to the previous talk, so we need not go through all the list again, but give me your top 3 barriers.
Is that question for me?
What are the top 3 barriers to research for medical students?
So just before I jump into that, I think what you've given us is not like a future agenda or a future goal, but something that's in our present and we're already working on also. Lovely. In different capacities. So it's nice to know. I mean, if nothing, it's nice to know that we are headed in the right direction. I think that's what I've realized over the last couple of minutes. Jumping on to research barriers, I think the top 3 barriers for me, as Nazreen rightly mentioned, is not having a mentor or not having somebody I can look up to and just say that this is what I want to be. If you just ask any random student from a medical college, they can point out to a surgeon and be like, that is the surgeon I want to be like. But why don't we have researchers that we can point out to? So I think that was one thing for me. And I have been fortunate to find somebody like that, but it took me some difficulty in getting over some barriers. I think the next one is the biggest barrier apart from this is being said over and over again, you're too young to start. By even established researchers, like what is the right age to research then according to you? And that's a question nobody's really been able to answer.
Fantastic.
But yeah, over and over again, when you go to one cave and then you go to the next cave and you go to the third person, you go to the fourth person, all of them have just the same thing to say. You're in first year, don't start now. You have a lot of time. What is a lot of time? 4 years from now, you expect me to write a PG thesis. So can you tell me how, like, is this some sort of a joke? I don't understand. So I think a barrier has been to just break that stereotype of you're too young, and just to be able to start when I think I'm ready to get started with my research work. And I think the third barrier has also been not able to form research groups, or a lot of this research work is just stuck in my college or stuck in my university. And nobody's paying me to do this or threatening me to say this, but my college has a relatively nice mechanism to um, encourage students to do research. Despite that, I've seen these gaps. But I think one big gap is that all of this is just on a very college level. And how we're trying to mitigate this is also through MSAI again, where we're developing a mentorship program so people can collaborate on research projects with different level of expertise, etc. But yeah, for me, the top three barriers that I've faced in the last 3-4 years would be these.
Fantastic. So I'm going to ask Adit from your postgraduate experience, and then we'll move on to Pratima in discussing these barriers.
I think out of the three main
Your
barriers,
top three.
the first and the most important barrier that is happening in research in India is our complete focus on academics and theoretical examinations. The system values marks more than anything, and as a result, the students and the professors also focus more on marks. The importance of the research has never been given importance in our curriculum, be it in UG days or during post-graduation. And the little research that is happening in colleges is more focused on epidemiology and not actual lab researches. The second issue, which I think is hampering research, is there are hardly any expert advisory panels readily available to students, which I think Ms. Nazneen also pointed out, the lack of mentors that are readily available to students. Experts who themselves have done some amazing research work in multiple areas, who can guide the students, create awareness, and also help the institute make a name for itself. And the last and also an equally important barrier is the unavailability of funds for conducting research. Students and institutes are left dry when it comes to funding of research work. We have the manpower, the number of patients, the time, and the energy, but no money to do some genuine research work. I mean, organizations like AIMS, NIMHANS, and PGI Chandigarh do promote funding for research work and are leading institutes in the world. But that has to trickle down to all the smaller institutes and colleges in the country for there to be an actual change. So these are the three main barriers I feel are hampering research in India.
That's fantastic. Dr. Pratima, I'd like you to comment on these two comments and give your perspective.
So I just, listening to Purva, I just felt, Purva, you're already dated. And nowadays people are doing research in primary, middle and high schools. I remember a little experiment somebody did on looking at a bean plant and how well it grew with ordinary water, microwave water, and boiled and cooled water as a school experiment. So, I mean, I think it's amazing actually how things are changing, but perhaps they need to change also in our medical colleges. And as you rightly pointed out, I think the emphasis ought to be on the necessity of research, especially translational research. I think we're at a time in our country where we need a huge amount of translational research to guide, both the treatment and policy. And I think looking at what can you translate from benches, which tend to do basic research, to the bedside, to the community, are all extremely important. So from that point of view, I think we need to make research more attractive, more relevant, especially to our medical students. And I think we need to defocus from just doing dissertation-led research to doing so many other ways of carrying out research, including reviews of topics, including presentation of case series. There are so many ways of doing it. So encouragement to research, I think, is an absolute yes. And I think those of us who mentor students to do that actually find that we learn in the process. It's a delightfully, mutually enriching process. And I no longer believe that it's only the teacher who teaches and the learner who learns. I think this has to be a bi-directional approach where we kind of actually learn from each other. And I think the days of passive teaching are long gone. Simply didactic teaching in itself is simply not enough. You need problem-based teaching, problem-based learning, and of course, application of good research questions to these. So those are my thoughts.
Awesome. So I'm going to go back to Dr. Reddy on this, and I'm going to do a little bit of what Karan Thapar did to you some time ago. I'm going to pin you down and say 5 action items to involve what you can do to make a real cultural change and involve medical students actively in research.
Well, obviously, I'm not going to count 5, KK. I don't believe in this. Name 3 things, name 5 things. That's too medical student oriented, too conventional.
Yeah, I'm sorry.
if I may say so. Okay, let's get on with this.
So you handle Karan Thapar so well, and I can understand why you did that.
Okay, right. Well, let me put it this way. I think it's important for us to recognize that the change will have to come. We have to nudge our teachers to accept the change, to support the change, and encourage the change. And that will come in essentially if the teachers are also participating in some research activities. For example, when you go to a medical conference and some of the faculty are presenting papers, they are questioned. And then they're not supposed to take it amiss. That's supposed to be part of the scientific spirit, to be questioned and cross-questioned and learn from each other. If we can actually encourage our teachers to be much more open to questioning themselves, that will be helpful. Secondly, I think the students should not feel that they are only going to be dependent on the teachers to rouse their curiosity or to guide their research aptitudes. I think given the current availability of technology and access to so many journals, they should be able to explore a lot of self-directed learning and form discussion groups among themselves in order to actually explore the avenues of knowledge. And then I think there is usually a consensus that students can actually do some research projects with the support of the faculty if possible. But I think if we can actually encourage group projects, and if not publications in leading journals, at least some degree of publicity given to their projects, that will be helpful to promote that kind of an aptitude for research. But I think we recognize fully that there will be teachers who will be of different kinds, just as parents are of different kinds. There are strict disciplinarian parents who don't encourage free thinking and questions. Similarly, there will be teachers. But that should not inhibit the child or the student to explore knowledge on their own, particularly through peer group interactions. And I think peer group interactions are going to be absolutely critical. And in the current time, we ought to be able to really explore how we can utilize all the learning channels. But also, I think it is important to have good student feedback, even if it is anonymous student feedback. It is important that teachers get the feedback about not only how they have taught, but how they have mentored or how they have tormented, and then ensure that the teachers are also made aware that they're appreciated by students if they encourage curiosity, if they support investigation of interesting research questions, and if there is a good open spirit of inquiry that is fostered in the discussions. So I think that feedback to the teachers is also going to be critical, and perhaps the Medical Council of India should build in student feedback as one of the important methods for nudging teachers also to change.
Dr. Reddy, I have to ask one final question. I think we've run out of time. So I'm going to ask this question to Omnia, and then I'm going to ask you to comment on that question. And the question is, can we create the 21st century physicians that can contribute to the community at large, in addition to treatment of individual patients? Is this a utopian dream, or is it something that we can work towards? Omnia.
Yes. Thank you for your question. And I would like to really share how working in IFMSA really gave me the exceptional experience of seeing the efforts of students worldwide. And I would love to say, I'm very proud to say that they are already doing that. There are medical students worldwide in many countries that are continuously contributing to their own communities and giving back and helping them, not just through their education while studying different disease management and so on, but more about raising awareness and doing a lot of screening, as well as and one of the very simple examples that I can give is our own response as PHFI, as medical students worldwide in the COVID-19 pandemic. We have seen activities in over 95 countries led by medical students who either volunteered to help COVID-19 patients, or they started raising awareness about how to protect yourself from COVID and how to protect your loved ones, as well as teaching their own communities how to do that, either online through social media and different communication channels, or offline by going to these different places that are inaccessible and they are vulnerable, and helping them to be protected from the pandemic. So this has been really it's not I believe it's not a utopian dream. The idea is that there has to be more empowerment and more push from the faculty side to provide a space for us to become more aware of not just our patients but our communities, to think outside just the disease but more about the factors that are impacting. I would really like to highlight the importance of addressing social and environmental determinants of health whenever we think about the health outcomes of our patients and our communities, and just giving the space for students to be part of their own empowerment, of their own education, working together with them, which really reflects back to Fletcher's ideology of meaningful student involvement. So giving them the space, because students really have the proactiveness, they have the passion to become better and to be more aware of their own community's needs, and to serve to that and to be empowered, and not just the community's need but also the health, the needs of the environment and the planet which sustains us. We really need to think about that as well, and this is really important in the formulation of the 21st century physician. They need to be understanding and aware of for example, impending health crises like climate change, like other health emergencies like the ones that we're living now. And maybe today's health emergency, COVID-19, is a wake-up call to really engage students and to prepare them, because we have seen how our education systems have not been strong enough to make us aware and understand of how to protect ourselves during such an emergency. So maybe this is also another push to really create more stronger, more resilient, and more aware 21st century physicians of the needs of their communities, as well as the environment that sustains them.
Thank you, Omnia. And Dr. Reddy, you started with the opening remarks, so you have to give the closing ones as well. And I think we have to wind up with that. So I'll have you maybe...
Well, I would have rather had the students make the closing remarks, because they are the ones to carry the mandate to the future. But since you've asked me, let me say that change is inevitable. If you do not actually try and prepare for the change and also become change makers, you are going to become the victims of either a continued inept medical system, or you're going to become the passive accomplices for something that goes wrong in the future. So as technology is going to be advancing, you're going to see the medical industrial system becoming more and more powerful. The role of the doctors will get marginalized unless they start addressing health system and social determinants of health. And they also have to bring in the ethical dimension to the appropriate use of technologies, along with an economic dimension. So they have to grapple with larger issues. Otherwise, you're going to see that doctors will ultimately become pure technicians, and even that may become redundant in the future at the rate in which you're getting technologies to replace medical professionals. So the medical professional will have to redefine his or her role and actually lead the change, use technologies appropriately, but necessarily ensure that their relevance to good, ethical, and appropriate patient care is well defined by the doctors themselves. And the health system itself is putting its resources to best use for both preventing disease, recognizing disease early, and treating and remediating illness as well as possible. So unless the doctors are running the ship, you will find that either the medical industrial complex is going to be running the ship, and the doctors will actually only become the load carriers. I think the young medical students will have to ensure that their future is not going to be compromised that way, and they have to create an efficient and equitable health system which they can actually lead, even with the help of the best of technologies as we are going to have in the future. So it is very, very critical that they become the change agents now so that they can actually become the leaders of the future.
Those are extraordinary closing words. I think it's just powerful messages that I was very apt at the end of this fantastic session that we've had. I have to thank everyone who have participated in this panel, and also the Medical Student Association of India to have really facilitated something quite special. Thank you all.
Thank you so much, sir. Thank you so much to all the panelists. Thank you so much to all the eminent speakers we had from Public Health Foundation of India. And thank you so much for making the entire session a very, very great success. I'm sure that all our participants gained a very solid perspective about research in public health, which is comparatively a gray area for the students, and I'm sure that this session gave them a lot of clarity on various thematics on research and public health, and both of them combined. I would want to inform the participants that there is a link to a form which we have shared in the chat box. Kindly fill out that form. It's a post webinar form for us to assess the session and for us to improve on any part we can. And thank you so much again to PHFI to arrange and to coordinate with us on such short notice, and to to help us arrange such a wonderful session for all the students. And with that, I would like to finally close today's session. We went a little overboard, but I can see it, and I'm sure that it was completely worth it. So no regrets on that. And thank you so much again. And with that, we would like to close today's session. Thanks a lot.
Thank you.
Thank you, everyone.